All right, as you heard, I'm from New Orleans. I've been practicing more than 13 years. I did also recertify in both internal medicine and endocrinology. So what I hope to do is point out some concepts that I've seen in my board recertification testing along the way. The plan is to pretty much go over all of endocrinology in these few hours that we have together. So since this is a review course, let's start off with a question. A 33-year-old obese woman with fatigue and inability to lose weight comes in for evaluation. She's internet savvy, as a majority of our patients are, and she questions if she has cortisol excess because she has 18 of the 20 signs that are listed on the internet. She does have diabetes and she's on metformin, but she does not have high blood pressure. She's obese by BMI of 38. Her blood pressure is 130/80. She has central obesity and pale striae. She comes in with basic labs of a normal TSH, which was very disappointing to her because she thought she could also have hypothyroidism, and her A1C is 6.6. Which of the following is the best screening test for cortisol excess? Random cortisol, ACTH-stimulated cortisol, 8 a.m. cortisol after dexamethasone, or 8 a.m. free cortisol? I'm glad I'm here. The answer is C. So let's talk about why that is the right answer, and probably more importantly, why the other ones are wrong answers. So 8 a.m. cortisol after dexamethasone is a very reasonable test to figure out if there's cortisol excess. One of the fundamentals of endocrinology is dynamic testing. So if you want to ask, is there hypersecretion, we're trying to suppress something, versus if it's low secretion, we try to stimulate it. And we're going to talk on the next slide about that. Why the other ones are wrong. Random cortisol, actually random hormone levels in endocrinology are very rarely useful because we like to take things within a context, whether it's after a medication, whether it's the time of day looking for a diurnal rhythm. So random levels very rarely help us. B, ACTH-stimulated cortisol is a test for adrenal insufficiency because we're asking if it's low, we want to stimulate it. And 8 a.m. cortisol is rarely useful. The context that it would be useful is if you're asking if someone has adrenal insufficiency, but you can't do a stimulation test, say they're right after pituitary surgery. If you get an 8 a.m. cortisol less than 3, it's likely adrenal insufficiency, versus an 8 a.m. cortisol greater than 12, it is very unlikely to be adrenally insufficient. Now, the other two options you have that you can check for cortisol excess, in addition to doing the 8 a.m. cortisol after DEX, would be a 24-hour urine-free cortisol or a midnight salivary cortisol, looking for that diurnal rhythm or the loss of the diurnal rhythm, which would happen with cortisol excess. So when we talk about the basics of endocrinology, if you want to test for hyposecretion, we want to stimulate it. The best test is an ACTH stimulation to rule out adrenal insufficiency. If you want to test for excess of a hormone or hypersecretion, we try to suppress it, like a dexamethasone suppression test to rule out cortisol excess. Random hormone levels are generally not helpful to us because, again, it needs to be within a context. Other basics. The term primary generally refers to the gland itself. Primary hypothyroidism, primary adrenal insufficiency, primary hypogonadism is at the level of the testes or the ovaries. Secondary refers to the gland that's controlling it, the master gland. So generally pituitary disease will cause secondary hypothyroidism, secondary adrenal insufficiency, secondary hypogonadism. Versus tertiary, it refers to the supreme gland, what controls the entire axis. It is hypothalamic control. But when you talk about clinical context or board context, we very rarely use the terminology of tertiary because we can't really assess for those hormones. We can't really check for those peptides. So for boards and clinical practice, it's very important to understand the difference between primary and secondary disease, but tertiary is not very important to understand. So when we talk about pituitary disease, we're going to talk about the pituitary gland, which is considered the master gland. And again, when you talk about hormonal deficiencies, the terminology is going to be secondary hormonal deficiencies when they come from the level of the pituitary. The pituitary has two parts, the posterior and anterior pituitary. For those that are visual, I will have pictures in there to show you. And so when we talk about the pituitary gland, we have the anterior pituitary, which is here, and it's 6 hormones that it makes. And we have the posterior pituitary, which doesn't make hormones, it stores hormones. And the hormone that we're going to focus on that it stores is called antidiuretic hormone. Again, this is under the regulation of the hypothalamus, but from a terminology standpoint, we discuss it at the level of the pituitary. So when we talk about the posterior pituitary, it stores and releases antidiuretic hormone, also known as vasopressin. It also does oxytocin, but doesn't have much clinical relevance in adult life, so we don't talk about it. So ADH stands for antidiuretic hormone, and it is a water hormone. It does nothing else but control water excretion at the level of the kidney. So even though we'll talk about antidiuretic hormone in the context of sodium balance, in the context of hyponatremia, it doesn't do anything directly to the sodium. It influences sodium through water regulation, so it is your water hormone. It is regulated by serum osms, and again, it controls urine concentration at the level of the kidney, how much you're going to pee out of water, and when the serum osms get high enough, it will also impact thirst along the way. But the first thing it does is urine osms, urine water. When there is a deficiency at the level of the posterior pituitary, the terminology is called central diabetes insipidus. You suspect diabetes insipidus when you have marked polyuria, and that's generally more than 2.5 or 3 liters of urine output a day. And the confirmatory testing is called a water deprivation test. So what a water deprivation test looks like for someone who is normal, and normal is the black line here, is that when you start to have limited access to water or you start getting dehydrated, your plasma osms will slowly creep up because you have less water available. As your plasma osms slowly creep up, change a minor amount, you are going to see that there's going to be huge changes in urine osms, meaning we're going to try to concentrate our urine to keep our free water to prevent the serum osms from going any higher. We want to prevent hypernatremia, prevent dehydration. So very small changes in plasma osms leads to huge changes in urine osms, and that is because of antidiuretic hormone. That is what is regulating it. So in the context of a deficiency at the level of the pituitary gland, where you have central diabetes insipidus, what you are going to see here is that you have increase in plasma osms when you have limited access to water, but you don't have any change in urine osms because you don't have the hormone that's necessary to maintain free water at the level of the kidney, so you cannot concentrate your urine. And then there's endpoints to the test, and you see when the serum osms are going up or their serum sodium's going up or they have weight loss of a certain amount, you give the medicine of DDAVP. And what you're going to see at that point, then you get this beautiful concentration of the urine osms because the kidney responds very nicely to it. So all of a sudden now you're concentrating your urine, you're not letting out any more free water, but the trick to resolution of this hypernatremia is not the DDAVP alone. It's giving this person back free water, because DDAVP will only keep water, but to restore the person back to balance of hydration and to restore the normal sodium, you need to give fluids. One of the more common causes of central DI is pituitary surgery, but it can also be seen in trauma and sarcoidosis, which is an infiltrative disease. When we talk about nephrogenic DI can either be congenital or acquired. When we talk about it as acquired, the two common scenarios that I see it is with lithium use and hypercalcemia. That's why we'll talk about hypercalcemia, how patients get into trouble, is because when they have the hypercalcemia, it induces a nephrogenic diabetes insipidus. They start peeing more. As they pee more, they get dehydrated. As they get dehydrated, it worsens the renal functions and worsens the hypercalcemia. So one of the mainstays of hypercalcemia that we'll talk about is fluid management and hydration, again, to try to target the acquired diabetes insipidus. And so what does it look like here? And so as you have limited access to water, your plasma osms will go up. They get the DDAVP, but you'll see that there's no response because this is resistance at the level of the kidney. When there is congenital nephrogenic DI or something like lithium-induced DI, the treatment will be diuretics, and that'll be more in your nephrology section. Make sense? Okay. So now we're going to move on to the anterior pituitary. And again, the anterior pituitary is under the regulation of the hypothalamus, and it is going to make our 6 hormones that we're going to talk about. The 6 hormones are going to be ACTH, TSH, FSH, LH, growth hormone, and prolactin. And one of the fun things about endocrinology, one of the neat things, is you generally lose first what you need least. So when I'm talking to my fellows and they're like, oh, I wonder if there's a pituitary problem, if it's a young woman, I ask, are there periods? If the periods are normal, I'm very reassured that their pituitary axis is okay. If they're young men, I ask about getting erections and maintaining erections. Again, you lose first what you need least. So if you are still making sex hormones and growth hormones, it is very likely that you have a good pituitary gland that's functioning. We talk about it in this context, empty sella syndrome. So empty sella syndrome is one of those things that's generally incidentally found on imaging. As our imaging is getting better, we're finding all things that we never really wanted to know about. And empty sella is one of those. The likelihood of empty sella causing a pituitary dysfunction is very, very, very rare. In fact, less than 10% of the times do you find anterior pituitary dysfunction. All it is that when too much CSF gets in there, it just squishes the pituitary against the bone. And so generally the pituitary is still healthy enough to make the hormones. It's usually seen in women that have had more than one child, and we just ignore it if all systems are functioning. But you get the patient that's very well read and said, okay, I really want my pituitary checked. Well, again, they're a young woman, you ask about periods. You can cheat and, check a growth hormone, but you don't want to check a growth hormone because it's too pulsatile, so we would check an IGF-1 level. If they're having periods, if the testosterone's normal, if growth hormone's normal, I just say forget about this empty sella syndrome and just move on with it. Because again, you'll lose first what you need least in the pituitary world. Question 2. A 24-year-old woman is found to have an incidental 7 millimeter pituitary adenoma and an otherwise normal MRI. You order the imaging because she was complaining of headaches. Again, incidental omas. We see a lot of these in endocrinology. She's on birth control with regular periods. Her BMI is 31, making her obese. Her blood pressure is 120/77, heart rate 70. She has a normal TSH and a normal CMP. Which of the following is the next best step in this patient's care? Check a free T4, check all anterior pituitary hormones for hyper and hyposecretion, plain old reassurance, neurosurgical evaluation, or check a prolactin and IGF-1 and consider screening for cortisol excess. I love being here because y'all need me again. This is good. The answer is E. So let me go through why E is the correct answer. You might end up being at C for reinsurance, but you can only do reassurance if you prove that this is non-functional. So with pituitary incidentalomas, it's going to be the size that dictates the evaluation, which are going to be on the slides coming up. And so for everybody that you find an incidental pituitary adenoma, you want to say, is it functional? So you generally want to check a prolactin level. Would you need a prolactin level if she were not on birth control? No, because you would ask about regular periods. If someone has regular periods, I'm not worried about hyperprolactinemia. But since she is on birth control, it could mask a prolactin level that's elevated because she is having regular periods. It's really hard to diagnose acromegaly, and acromegaly diagnosis generally lags years and years and years behind initial presentation. So that's why we recommend screening for for growth hormone excess with an IGF-1 whenever you find an incidentalloma. And then you consider screening for cortisol excess and all if there's reason. Now, you don't necessarily have to do testing, but you want to think about it. See if this person has striae, see if they have proximal muscle wasting, see if they have thin skin, easy bruising. So you would only check a free T4 if you suspect a TSH secreting pituitary adenoma, which would not be the case here because clinically that's not how she's presenting. You only check for hyposecretion if it's large enough to squish the gland, okay? So at greater than a centimeter, you would entertain screening for hypofunction, but anything that's less than a centimeter is not big enough to cause problems with hypo. And you would only do neurosurgical evaluation if you prove cortisol excess, TSH secretion, or acromegaly. If it is a prolactinoma, that's medical management. So you would only do reassurance after you made sure it was non-functional. So pituitary tumors, often found incidentally, size dictates evaluation. If it's less than a centimeter, you're asking, is there hypersecretion? If it is greater than a centimeter, you're asking, is it making hormones? Is it so big that it's squishing the pituitary gland and it can't make the other hormones? And is there visual fields deficits, okay? Because you want to get formal visual fields testing in these people to make sure that there's not compression of the optic chiasm. So prolactinoma would be the most common secreting pituitary tumor that you're going to find. Generally presents in younger people, and the prolactin level will decrease the sex hormone production. And so these people will often present with amenorrhea or hypogonadism. And what you're going to find is in women, they oftentimes present earlier with smaller tumors, because with women, the moment the periods start going away or you have galactorrhea, it raises a red flag, so they come to the providers a lot earlier for evaluation. Versus men, oftentimes it presents later and they're larger tumors. And the reason is because men are quicker to explain away symptoms of low libido and erectile dysfunction. So they deal with the symptoms for a long time until it's gotten to the point where they do need to come and present. So it's not that the disease is more aggressive in men, it's just that it's found later due to kind of pushing the symptoms aside, versus in women they tend to present earlier because of the absence of periods or the galactorrhea. So when we talk about prolactin, it is important to recognize that prolactin is the only hormone that's under negative feedback of the hypothalamus. It's under negative inhibition or tonic inhibition of dopamine. All the other anterior pituitary hormones, the other 5, are under positive feedback. So prolactin is made in the anterior pituitary, and then it stimulates the breast tissue to have galactorrhea. The prolactin will then go and shut off sex hormone production via GnRH at the level of the hypothalamus, thus causing amenorrhea and hypogonadism. It is important to remember that other things impact prolactin levels, including TRH and estrogen. So part of the mainstay evaluation of hyperprolactinemia is to always rule out pregnancy in women and hypothyroidism as a cause of the elevated prolactin level. So drug treatment or medical management is the mainstay of treatment independent of the size of the pituitary tumor. Prolactinomas are exquisitely sensitive to dopamine agonist therapy. So whether it's 2 millimeters in size or 2 centimeters in size, we are going to be using dopamine agonist therapy, and cabergoline is preferred. It is rare that we would do surgery. We would do surgery when medications are not effective. And again, this would be a little bit of a red flag for us because generally they should be exquisitely sensitive. The more common scenario for surgery is when people don't tolerate the dopamine agonist therapy. It can cause nausea, it can cause orthostatic hypotension. Sometimes people just don't do well with medical management. If you do have a prolactinoma, you do want to be cautious of using estrogen therapy because it can increase the size. So prolactinomas can get larger during pregnancy, they can get larger when you start birth control or postmenopausal estrogen therapy. Remember that tumors are not the only etiology of an elevated prolactin level. One of the more common etiologies are medications. So you always want to look at the med list to see if there's any agents on there that could elevate the prolactin level. And you also, again, want to think about hypothyroidism and pregnancy, in addition to end-stage renal disease, as a reason for elevated prolactin levels. And the fun part about prolactinomas is that the elevation of the prolactin level does correlate with tumor size. So you can rest assured, as your prolactin level is coming down to 200 to 100, there is shrinkage of that prolactin. As levels normalize, you can be reassured that the tumor is not growing. That being said, you probably will follow up with serial imaging, but you can let your prolactin level be a guide as to how often imaging is needed along the way. Next case, 52-year-old man complains of headache and fatigue for 2 years. No real significant past medical history. On review of systems, he has snoring, he's got fatigue, he's got exertional pain in his knees and ankles, he's got some paresthesias and pain in his right hand that wakes him up from sleep. His BMI is 31, so he's obese. His blood pressure is elevated at 165/94. He has coarse hair and skin on his face, laterally displaced PMI, normal TSH, normal CMP. A1C gives him a diagnosis of diabetes at 8.6, and on a screening colonoscopy that he had 2 years ago, there were polyps noted. Which of the following is the next best step in this patient's care? Check a TSH with a free T4, check serum growth hormone, order a sleep evaluation, start metformin, or check a random serum IGF-1. E. E is the correct answer. So let's talk about the other ones. So pairing a TSH with a free T4, you would do that in the context of secondary hypothyroidism, that you were suspecting that along the way. And based on his clinical history, we don't have any reason to suspect that. I do like the fact that you're thinking growth hormone excess, but the problem with growth hormone is too pulsatile. You can't check growth hormone levels because they could be anything throughout the day. That's why you want its end product, which is the IGF-1. And it's not that a sleep evaluation and treating the diabetes with metformin is not a good idea. In fact, it's a wonderful idea, and you would do that. But the problem is it's not going to get you your diagnosis. And your diagnosis at this point is acromegaly. So you're going to find that in boards, rare diseases are common. But, we want you to be thinking about these things. And so we're going to talk about PHEO and acromegaly and insulinoma along the way. But in practice, you're not going to see it too often. The classification of growth hormone excess is based on age. So in kids, when we find growth hormone excess, it's called gigantism because they grow linearly because their growth plates are infused. In adults, we call it acromegaly because there's acral growth or bony overgrowth because your growth plates are fused, so you will not gain height. You'll just gain more soft tissue and cartilage tissue. Classic finding: enlarging hands and feet, frontal bossing, deepening voice, coarse facial features, excessive sweating and body odor, and jaw malocclusion. Screening test, best test is always an IGF-1 level. You'll confirm it with dynamic testing, where we'll use a 75-gram oral glucose tolerance test. Growth hormone fails to be suppressed with the hyperglycemia. And again, this is one of our basics of endocrinology. If I want to ask if there's hypersecretion, I try to shut it off. Everybody with the diagnosis of acromegaly gets surgery, even if the tumor is very small in size. The moment you find that there's a functional growth hormone tumor at the level of the pituitary, it is surgery for everybody. Okay, fun fact. So we said that if we want to check for hypersecretion, we're going to shut it off with a 75-gram glucose test. What is the gold standard test for growth hormone deficiency then? Insulin-induced hypoglycemia. Yes, we rarely do it. But if you were to talk about the gold standard to stimulate my counter-regulatory hormone of growth hormone, or cortisol for that matter, it's insulin-induced hypoglycemia. So again, this is how we manipulate the endocrine system to ask the questions, are we making too much or too little of a hormone? So in acromegaly, we want to look for heart failure, so everybody gets an echocardiogram. We want to look for polyps, so everybody gets a colonoscopy, and everybody needs a sleep evaluation. And it should be done prior to surgery, because oftentimes these people do have profound sleep apnea. You want to look for palate edema, because these people can be very hard to intubate and extubate along the way. So again, for those that are visual, you're going to find that growth hormone is made by the anterior pituitary under regulation of growth hormone releasing hormone. Its end product is made at the level of the liver, which is called IGF-1. And it's the IGF-1 at the level of the liver then will feed back on the hypothalamus and the anterior pituitary. So let's talk about our first endocrine emergency, pituitary acromegaly. Your job on the boards are going to be to recognize it and treat it. So this is a context where tumor outgrows the blood supply and bleeds into the pre-existing tumor that's there. The majority of the time, people do not know that they have these tumors. The majority of the time, it'll be an older person. The majority of these tumors will be non-functional tumors. The usual presentation: severe headache, worst headache in my life, nausea, vomiting, visual field deficits with cranial nerve deficits, and altered mental status. You will see the bleed on CT. And your job is to give glucocorticoids and to call your neurosurgical colleagues. And again, the context on the boards will be recognizing it by its classic presentation and given glucocorticoids. Neurosurgery will come along the way. They may or may not do decompression. No other anterior pituitary hormone is important at this time. You know, we already talked about the luxury hormones of sex hormones and growth hormone. No one cares about those. You might say, well, what about thyroid hormone? Thyroid hormone has such a long half-life of a week, you have time to figure out what's going to happen with the thyroid axis. Versus cortisol, such a short half-life, you need to give it immediately and in stress doses at the time of diagnosis. Okay, so let's talk about thyroid disease. So TSH is made by the anterior pituitary in response to TRH made by the hypothalamus. The TSH will then go to the thyroid and make thyroid hormone. 80% of what the thyroid makes is T4, 20% is T3. T3 is the more active thyroid hormone, so we generally make T3 in the periphery by peripheral deiodinases. Okay, so when we talk about the mainstay of treatment for replacing thyroid hormone deficiency, it is going to be T4 alone. It's the thyroid hormone T3 and T4 that will then go back to the hypothalamus and anterior pituitary and shut off TRH and TSH production. So thyroid basics. TSH is always the best screening test. And again, don't be coerced by your patients or confused on boards. We don't need a reverse T3. We do not need ratios. We do not need free T3 levels. We only need a TSH level. Unless you're concerned about pituitary disease, then in that context, you will pair it with the free T4. But the all-comers, the routine, I got brain fog, I got fatigue, I have hair loss, I have inability to lose weight, I'm just not myself, TSH is the best screening test because it is a really good assay. You'll see a low TSH in hyperthyroidism, again, because it's shutting off pituitary. You'll see a high TSH in hypothyroidism. And again, you should only order both in the context when you suspect pituitary disease or secondary hypothyroidism. More rules. TSH and free T4s should be inverse, remember, because they're regulating each other. So in the context of primary hypothyroidism, you expect a high TSH. There are some scenarios where they will run in the same direction, but the scenarios are unusual. You can see that they both will be low in pituitary disease, which makes sense. That's why you always want to pair TSH with a free T4 if you suspect pituitary disease. And the more common scenario where you'll see them running together is euthyroid sick, and we'll talk about euthyroid sick on the next slide. They both can be high in pituitary disease, meaning a TSH OMA, but you would have the classic presentation of classic hyperthyroidism and failure to suppress a TSH or resistance. I'm an endocrinologist. I just recertified in my boards. I didn't have one question on resistance, so I do not think you are going to see it on your internal medicine boards, okay? And I passed my boards just fine. I actually did pretty good on them. So you can rest assured what I'm telling you. I just didn't miss it. Okay, and so let's talk about euthyroid sick. They go in the same direction. Euthyroid sick is actually a sense of self-preservation. It's when your body will not convert to the more thyroid hormone, which is T3. Instead of converting our T4, which is our less potent thyroid hormone, to T3, we make inactive reverse T3. If you ever wanted convincing evidence that this is in fact sick euthyroid, send off a reverse T3, it'll be high. But your patient will either be dead or better by the time you get it back, because it's a send out. It takes about a week to come back. So it is never the right answer to do it. It's recognizing the clinical context that got you to answer the question this way. So you have a low normal TSH, a low normal free T4, a low normal free T3, and a high reverse T3. And again, we don't generally measure it. So thyroid is never the problem. So you should never check TFTs in critically ill patients unless you're saying, is this myxedema coma or is this thyroid storm? And again, your labs will show you if either is present. When you get your low normal of both, it's sick euthyroid, take a step back, put them on for serial monitoring in the labs weekly just to make sure that they're recovering along the way. So when we talk about hypothyroidism, by far the most common cause is chronic autoimmune hypothyroidism, Hashimoto's disease. One thing you need to recognize is that having thyroid antibodies is very common. 20% of the population, healthy population, has thyroid antibodies. So we only treat positive antibodies in the context of overt hypothyroidism. So again, we do not target Hashimoto's alone without having overt thyroid disease. Other etiologies of hypothyroidism, we can have a thyroiditis, which can happen within a year of delivery, which is called postpartum thyroiditis. There's some data you can treat with selenium to help ease this. You can have a post-surgical hypothyroidism, a painful thyroiditis, which is called de Quervain's thyroiditis. You could have medication-induced hypothyroidism, lithium, amiodarone. It is important to note over here, this graph is actually a thyroiditis graph. And what you'll find is generally thyroiditis has three phases. It has its hyperthyroid phase, which is the first phase, hypothyroid phase, which is the second phase, and your third phase is either recovery or developing overt hypothyroidism. When you talk about thyroiditis and hypothyroidism, you are talking about the second phase of thyroiditis. Other etiology can also be after I-131 therapy. The problem with hypothyroidism is the symptoms are non-specific. And again, this is a pain point for endocrinologists, a pain point for primary care docs, where patients are just convinced they have hypothyroidism because the symptoms are so ubiquitous. There are some signs of overt hypothyroidism where you can get delayed relaxation of reflexes, bradycardia, galactorrhea, because remember, hypothyroidism is a cause of a high prolactin level. Labs, you can see a lipid panel that's altered. That's generally if a TSH is greater than 10. Hyponatremia, because in the context of euvolemic hyponatremia, you rule out hypothyroidism as a cause of antidiuretic hormone release. You can see anemia, hyperprolactinemia. But the treatment, the diagnosis is based upon an elevated TSH level. If you were to check the free T4, it would be low in this context. Do we need thyroid antibodies? No. But if they were checked, they would probably be positive because, again, 20% of the population has positive antibodies. We want to treat all people with overt hypothyroidism. This is a high TSH paired with a low free T4. We also consider people treating subclinical hypothyroidism, and the definition of subclinical hypothyroidism is an elevated TSH with a normal free T4 level. The context that we would treat subclinical all the time is a TSH greater than 10, because this is where you can show that it impacts lipids. If they have a goiter, because we want to prevent further goiter growth with the hypothyroidism, and if they're pregnant or trying to get pregnant, because the name of the game in pregnancy is a TSH less than 2.5. Other than that, it becomes a gray area and a discussion and not a board question. No imaging is needed in hypothyroidism unless you feel a nodule. And then if you do feel a nodule, you want to go and get an ultrasound. So how do we treat hypothyroidism? T4 is the standard of care by any guidelines, and that's what the boards want you to use. If they are young and healthy, you can do full replacement dose, which is about 1.6 to 2 micrograms per kilogram. If they're older, you start low and go slow as you tweak up the dose in order to normalize the thyroid test. Because thyroid hormone has such a long half-life, you do want to allow full 6 weeks before you start changing the dose. Again, the half-life is a week of T4. T3 is rarely used in practice. Patients love it. We rarely use it in practice. Boards, it will never be the right answer. Our societies do not recommend using T3. The problem with using T3 or to treating to symptoms is oftentimes it leads to exogenous hyperthyroidism. So I will never be the one to say that too much thyroid hormone won't make you feel better. It will. They still use hyperthyroidism as a treatment for severe depression. So it will make you feel better, but the risk-benefit ratio does not favor benefits. It favors risks, and the risks are AFib and bone loss. So we always treat to TSH and never treat to symptoms, and we don't really use T3 as part of our tool set to treat hypothyroidism. Let's talk about our next emergency, myxedema coma. It is a clinical diagnosis, meaning no TSH is going to predict coma. You can have a coma happening with a TSH of 15. You can have people that are just fine with a TSH of 200. You are looking for the symptoms of altered mental status, hypothermia, and bradycardia. In the context of hypothyroidism, if you have those clinical symptoms, you need to call myxedema coma at that point. The mortality is high, and it's actually related to the degree of hypothermia. You want to give people the thyroid hormone, and preferably IV, because they're probably not absorbing it too well at the level of the gut. But more importantly, before giving the IV thyroid hormone, you either want to assess for adrenal insufficiency or proactively treat for adrenal insufficiency, because it is not uncommon that autoimmune diseases can run together, and if you were to give the thyroid medicine without giving the cortisol, and there is in fact adrenal insufficiency, you're going to precipitate adrenal crisis. Know that you need to empirically treat with glucocorticoids before you give IV thyroid hormone, because if you don't, adrenal crisis. And then you want to do other supportive care along the way. Next question. A 6-year-old woman with chronic hypothyroidism comes in for evaluation of weight loss and palpitations. She stopped her hormonal therapy about 3 months ago. She's on levothyroxine 175 and she's taking calcium. On exam, she's tachycardic at 104. She's got a mild tremor, no goiter. Her labs show a low TSH and an elevated free T4 level. Which of the following is the next best step in her management? Thyroid uptake and scan, restart her estrogen, decrease her dose of thyroid hormone, check for thyroid antibodies, or advise her to take her thyroid medications 1 hour out after her calcium supplements. Good, the answer is C. So we would only do a thyroid scan and uptake if it is endogenous hyperthyroidism, if someone is not on thyroid hormone replacement. Estrogen therapy is controversial, so no, we would never jump to that, especially on boards. Antibodies aren't really going to help us because we know the most common etiology is of Hashimoto's, so I don't know how that would change anything. And we would only talk about separating her thyroid hormone from calcium is if her TSH were elevated, meaning it seems as if she's not absorbing her thyroid hormone. Thyroid hormone is fickle. It doesn't absorb too well with calcium. And so that's why we generally advise people to take it first thing in the morning, sip of water, empty stomach, wait 30 to 45 minutes before eating. So it would only be in the context if she were on a higher dose than you thought would be expected based on her weight. So the learning point here is that estrogen impacts thyroid binding globulin, and thyroid binding globulin is what carries around thyroid hormone. And so in high estrogen states, you oftentimes need a higher dose of thyroid hormone, and if you were to stop the estrogen, you need a lower dose. And so next we'll talk about hyperthyroidism. Hands down, the most common etiology of hyperthyroidism is Graves' disease. You see it in younger people, and it's autoimmune mediated. If you were to check antibodies, you would have an elevated thyroid stimulating immunoglobulin and or an elevated TSH receptor antibody, also known as TRAB. Other etiologies of hyperthyroidism would be a postpartum thyroiditis within a year of delivery, painful thyroiditis, again, de Quervain's thyroiditis. In older people, you could see a toxic multinodular goiter because nodules are more common as you get older. You can have exogenous hyperthyroidism, meaning we're taking too much medication, or you can have medication induced. So this is your 80-year-old that comes in with hyperthyroidism who had angiogram 2 weeks before. This is iodine-induced hyperthyroidism. Or amiodarone. Amiodarone causes 2 different kinds of hyperthyroidism. When you look over here at our thyroiditis graph, you'll find that hyperthyroidism is the first phase of thyroiditis. The hyperthyroidism usually morphs into hypothyroidism, and again, in the context of a de Quervain's or a painful thyroiditis, you get resolution. In the context of a postpartum thyroiditis, because it's associated with antibodies, you either have resolution, which is the majority of the time, or you can end up with overt hypothyroidism. So clues to diagnosis. If you have hyperthyroidism with Brui and or Graves' ophthalmopathy, that is Graves' disease. If it is within 1 year of delivery, it's generally a postpartum thyroiditis. If it is painful, we're looking at a painful thyroiditis, you can get a high SED rate and you're looking for a recent viral infection. Toxic multinodular goiter, again in that context of recent contrast or amiodarone use. And exogenous, they give the case of the overweight nurse. So someone who has access to thyroid hormone, they're trying to lose weight because it does help with weight loss. It's just not sustainable and it's not worth the risk-benefit profile. And the test you want to do here is thyroglobulin, because remember, every time you make or release thyroid hormone, even in a thyroiditis, you also are releasing thyroglobulin, which is the protein component of it. So making or destruction of thyroid hormone, thyroid gland, you will have thyroglobulin being elevated. In the context of exogenous, where I'm taking it, you're going to shut off your own gland production, so your thyroglobulin would be undetectable. Symptoms are that of symptoms of increased metabolism, weight loss, palpitations, diarrhea, anxiety. You could have gynecomastia in men because what happens in hyperthyroidism is it increases sex hormone binding globulin. And so the testosterone, even though it's normal, your free testosterone is on the low side, so that was reversible. You can get lid lag, AFib, tremor, goiter. You can see hypercalcemia, high alk phos levels. The test of choice is going to be a low TSH, and you would see an elevated free T4 and or free T3 level. Do you need antibodies? Generally not needed, because your scan, and I'll show you some pictures, will give you the diagnosis, but there are some scenarios where you might want to check it, like the context where you can't get a scan. They're on amiodarone, or they're pregnant, or they're breastfeeding, or they had recent contrast within the past few weeks. That way that can help you determine the etiology of the hyperthyroidism. And so remember, it's the imaging that's going to generally determine the etiology, and the imaging of choice is a thyroid scan and uptake. Remember, a thyroid scan and uptake is 2 parts. It's a pattern, and which is a picture, and then an uptake. So normal here, you see the 2 lobes of the thyroid gland. In Graves' disease, you're going to see that it's enlarged and it's homogeneous, and the uptake is going to be high. In a toxic multinodular gland, you're going to see patchy uptake, so areas of increased uptake, areas of decreased uptake. And in a toxic nodule, also called Plummer's disease, you're going to get one big hot spot, and it's going to suppress the rest of the gland. So this is going to give you your etiology of hyperthyroidism. Now, if it's a thyroiditis, whether it's a postpartum, whether it's a painful thyroiditis, or if it's due to iodine exposure, the gland's already going to be saturated, so you're not going to have any uptake or any picture in a thyroiditis gland. So independent of the etiology of the hyperthyroidism, one of the treatments is going to be beta blockers, but that is merely for symptom control along the way. It doesn't do anything to address the etiology of the hyperthyroidism. And for Graves' disease, you're going to have 3 treatment options. You're going to have medication, which is methimazole. And methimazole is a pretty good medicine because what you're going to find is about 30% of the patients who take methimazole for a year or 2 will go into remission. So it is not unreasonable to offer medical management up front. We only really use PTU in the first trimester of pregnancy because PTU has a black box warning associated with fulminant liver failure. So we'll use it in the first trimester, get past the concern of aplasia cutis, and then in the second trimester, put people on methimazole. You also have the choice of I-131 therapy. The times that you don't want to use I-131 therapy is if they smoke and or have Graves' ophthalmopathy because that can actually make it worse. And then the last treatment option is surgery. We don't do surgery too often for this, but there are times that we would consider surgery. So suppose someone wants to get pregnant now, or they are pregnant and we're having trouble controlling the hyperthyroidism. Suppose that someone can't tolerate antithyroid medication because of agranulocytosis or rash, and they're freaked out with the thought of radioactive iodine. So it's not that we don't do surgery for Graves' disease, but generally we have other treatment options before we get there. So when we talk about the other treatment options for postpartum thyroiditis, again, we would use beta blockers in that context of the hyperthyroid phase. For a painful thyroiditis, we would consider using NSAIDs or steroids, as it's generally sensitive to that, and then you taper off in time. For a toxic multinodular goiter, we would offer radioactive iodine therapy. And it's not that antithyroid medications wouldn't work, but it doesn't offer the advantage of a cure. So it'd probably be lifelong therapy if we were to use it versus definitive therapy. The radioactive iodine would just destroy the overactive nodules, and you would expect restoration of euthyroidism. So let's talk about our next emergency, which is thyroid storm. Mortality is high, like most of our endocrine emergencies. Like myxedema coma, it is a clinical diagnosis. There is no elevation of free T3 or free T4 that predicts storm. It is the context of hyperthyroidism plus altered mental status, fever, tachycardia is when we should be thinking of storm and empirically treating for storm. How we want to treat is we want to block production and formation of thyroid hormone with PTU. We want to use SSKI. We want to use steroids to block conversion, and we want to use beta blockers. If you are not confident making the call of thyroid storm, there are tables that you can use out there to help assess the risk. But again, the treatment, what you need to recognize, it's a clinical diagnosis. So you can have someone with a free T3 that's greater than the assay reads and not be in storm. You could have someone with a doubling of free T4 and be in storm. It's the clinical context that describes whether the diagnosis is present or not. So let's take a minute and just talk about pregnancy and the thyroid. So in hypothyroidism, because your thyroid binding globulin is increasing because of estrogen, your thyroid hormone needs will increase in pregnancy. The rule of thumb is by 30 to 50%, so you add on 2 extra pills a week for the pregnant patients. And then you check labs every 4 to 6 weeks. In hyperthyroidism, the name of the game is normalizing free T4 and not TSH. So remember, TSH is the goal in hypo. Studies show that if you normalize TSH level in pregnant moms, you're overtreating the baby. So what you want to do in hyperthyroidism in pregnancy is get a normal free T4 and let the TSH go low. Now, the good news is the most common etiology of hyperthyroidism is Graves' disease. Pregnancy is a time of immune tolerance, so generally Graves' disease does get better during pregnancy anyway, so it makes your job easier, and then you just get a flare after they deliver. Should you want to treat hyperthyroidism in the first trimester, it would be PTU, and then if it's necessary in the second trimester to address it, we would then switch over to methimazole. Next question. 32-year-old woman, pain in the right upper quadrant and fever for 2 days. She's jaundiced. She's put in the ICU. She's diagnosed with ascending cholangitis. Her heart rate has only been as low as 65 for the past 2 days. They checked TFTs, and the TSH is low at 0.2. The free T4 is low at 0.6, so both just below the assay normal. You are consulted for recommendations on the need for further evaluation and institution of thyroid hormone replacement. Which of the following is the next best step in her care? Order an MRI of the pituitary, start thyroid hormone PO, start thyroid hormone half the dose IV, reassurance, or order a thyroid uptake and scan. Good. This is reassurance. This is a clinical context of euthyroid sick. The labs are going in the same direction. It would be very unusual for this person to be presenting with pituitary insufficiency. It's just not the right clinical context. Plus, she's febrile and she's not having marked bradycardia. So again, this is euthyroid sick. By far the most common scenario, you're going to see the thyroid hormones going in the same direction. Again, it's just a context that you're getting these labs. Versus this clinical context. 49-year-old man with 4 months history of cold intolerance, fatigue, depression, weight gain, constipation, history of pituitary surgery 5 years ago for a non-functional pituitary adenoma, was assessed after surgery, did not have any anterior pituitary hormonal deficiency, so is not on anything at this point. His TSH is 0.5, low end of normal for the assay. His free T4 is the same, 0.6, so low for the assay. Which of the following is the most likely diagnosis? Chronic autoimmune thyroiditis, secondary hypothyroidism, hyperthyroidism, euthyroid sick, or no thyroid disease? So B, correct. Again, completely different context. So you were savvy to get the free T4 because this is a scenario you want to pair a free T4 with a TSH because again, even in overt secondary disease, your labs could be normal even though your end organs aren't making enough of the hormone needed. So you want to pair it in this context. The other things, the other answer is why they're not right. So in chronic autoimmune thyroid disease, you'd have a high TSH. In hyperthyroidism, you'd have a low TSH but a high free T4, and they'd be clinically hyperthyroid. Euthyroid sick, he's not sick. And again, he does have significant thyroid disease because it's at the level of the pituitary. And again, before you were to give him thyroid hormone, you would want to assess his HPA axis. You want to make sure that his adrenals are making cortisol and that he doesn't have ACTH deficiency. If you were to give thyroid hormone before assessing that he's not adrenally insufficient, you could precipitate an adrenal crisis. So the moment you're asking, is this pituitary-based hypothyroidism or secondary hypothyroidism, your due diligence is to assess the other anterior pituitary hormones before treating. Thyroid nodules. Thyroid nodules are really common. Up to 50% of people over the age of 50 have thyroid nodules. You will be able to feel a thyroid nodule in 1 of 20 of your patients. Thyroid cancer is not common. So your biggest job with thyroid nodules is to reassure the patients that they will probably end up keeping their thyroid nodules over time and they will not require surgery and it is not cancer. The likelihood of thyroid cancer in thyroid nodules is less than 10%. And currently, we do not advocate screening for thyroid nodules in patients that are not high risk. So what are the risk factors for thyroid cancer? Prior neck radiation, especially in childhood, a family history of thyroid cancer. We look for ultrasound characteristics such as solid nodules, micro or macro calcifications, irregular margins, nodules that are growing tall more than wide. You look for evidence of fixed thyroid tissue, dysphagia, dysphonia. Men have a higher chance. They're very young, very old. If you have lymphadenopathy, especially that's fixed and hard. If you higher the TSH level, because TSH will stimulate both normal thyroid tissue as well as thyroid cancer, because most thyroid cancer is fairly differentiated, well differentiated. And PET positivity. So I'm talking about focal uptake on PET. Focal uptake in the thyroid on PET has about a 40% chance of malignancy, okay? Versus diffuse uptake of the thyroid gland is just Hashimoto's disease, all right? So when you have a palpable thyroid nodule, first you want to do is check a TSH. TSH is your break point. TSH is low, you're getting a thyroid scan and uptake to see if it's a hot nodule. TSH is normal or elevated, you're getting a thyroid ultrasound. The thyroid ultrasound is then going to help you determine whether you are going to biopsy. So it's not just size alone that predicts biopsy, it's size plus ultrasound characteristics. And then, of course, we're going to think about what is the risk of malignancy, where we're going to have a lower threshold for biopsy, the higher the risk of malignancy. So what are the surgical indications? Surgical indications are abnormal biopsy, namely ones that shows malignancy or suspicious for malignancy, significant growth over time. We're looking for either growth in volume or 2 dimensions, or compressive symptoms will also get you surgery. And note the workup of incidentally found thyroid nodules on imaging is the same as nodules found on exam. So your person who goes to the fair and has the carotid ultrasound done, they find the nodule, would get the same workup as if you found the nodule in clinic. There's nothing special about it. Next question. You evaluate a 44-year-old woman with anxiety, weight loss, mild tremor, and tachycardia. She's got a non-tender goiter. Free T4 is elevated. TSH is low. Your nuclear scan shows you this homogeneous pattern, and the uptake is elevated at 59%. Which of the following is the most likely diagnosis? Graves' disease, subacute thyroiditis, silent thyroiditis, exogenous T4 intake, or toxic multinodular goiter? Excellent, Graves' disease. So remember, with Graves' disease, you're going to have symmetric uptake and it's going to be high. So your picture is going to show it. In any thyroiditis, you're not going to see uptake. And in exogenous thyroid intake, you're not going to see uptake. In a toxic multinodular goiter, you're going to have patchy uptake, areas of high uptake and areas of low uptake. Let's move on to adrenal disease. When we're talking about adrenal disease, we are talking about the anterior pituitary making ACTH in response to CRH from the hypothalamus. The ACTH is going to impact all 3 hormones made by the adrenal cortex, but it mostly controls corticosteroid production. It has a little bit of influence on DHEAS and a little bit of influence on aldosterone, but the biggest regulator of aldosterone is the renin-angiotensin system. So when you're talking about feedback, the biggest regulator that's going to regulate CRH and ACTH production is going to be the glucocorticoid production. And ACTH does not have anything to do with the adrenal medulla, okay? So the adrenal cortex makes the 3 big hormones. Again, cortisol regulated by ACTH, aldosterone, main regulator is renin, and androgen, DHEAS. So if you ever have a high androgen state and you want to know is it ovary or adrenal, you check a DHEAS. Because although the ovaries make DHEA and the adrenal make DHEA, the only place sulfation occurs is at the level of the adrenal gland, or 90% of it. So the way you differentiate is it adrenal or ovary is DHEAS, because again, sulfation is adrenal, and that's where you want to look if that is high. The medulla makes our metanephrines and catecholamines, our flight or fight, our adrenaline, and it's not under ACTH influence. When we talk about Cushing's syndrome, we're talking about cortisol excess, and you have your very well-described stigmata of proximal muscle weakness, easy bruisability, you have the fat pads, you have moon facies, plethora, obesity, thin arms and legs. By far the most common etiology of cortisol excess is exogenous steroid use. We tend to use steroids probably more frequently than we should, and some diseases are just more responsive to steroids than any other medicines that we have. When you're talking about endogenous cortisol excess, the most common is ACTH dependent, which is pituitary disease, also known as Cushing's disease. Cushing was a neurosurgeon, that's his disease. You have ectopic ACTH dependent cortisol excess, and then you have ACTH independent cortisol excess, which is the adrenal gland just making cortisol without being regulated by ACTH made from the pituitary. What you're going to find in endocrinology is we never jump to imaging. We don't love imaging. Incidentalomas plague us. So we always want to screen, confirm, and then once we confirm it, then we localize, okay? Then we do imaging. So imaging never happens before a confirmatory diagnosis for us. Your choices for screening for cortisol excess are 24-hour urine-free cortisol, noting that the pitfall for this is that in depression and alcoholism, you can have false positives. This is called pseudo-Cushing's. You can do a 1 milligram overnight dexamethasone test, noting that the pitfalls are if they're on birth control or estrogen, that increases cortisol binding globulin. So you have a higher chance of having a false positive. Now, that being said, if someone's on birth control, you give them dex and they suppress to less than 1.8, you've excluded it. If they don't suppress, but they're on birth control, you say, oh, it might be a false positive. I'm going to do other dynamic testing along the way. And then the other thing you can do is a late or midnight salivary cortisol, because we're taking advantage of the fact that cortisol has a diurnal rhythm, highest in the morning, lowest at night. So we're looking for that nadir at night. Pitfall, shift workers, what do you do with them? It's really hard to know what their diurnal rhythms should look like. So again, 3 perform about the same, but you just need to know your pitfalls in dynamic testing before you order them. And then again, we always want to confirm abnormal testing. Once we are convinced we are looking at cortisol excess, now we want our breakpoint to be, is it ACTH dependent or is it ACTH independent? Because that is going to dictate where we look. If the ACTH is low, meaning it's ACTH independent, I'm going to look at my adrenal glands. If the ACTH level is not low, I'm going to look at my pituitary, and then if my pituitary is negative, I'm going to look for ectopic ACTH production. And I specifically have here if ACTH is not low, meaning it doesn't need to be high. So another rule of endocrinology is if you are making too much of a hormone, you should shut off what regulates it. So in the context of normal hormone that's regulating it, when you have a high endpoint hormone, that is considered inappropriately normal. So an inappropriately normal ACTH in the context of cortisol excess is ACTH mediated. An inappropriately normal PTH in the context of hypercalcemia is PTH mediated. So it doesn't need to be high to mediate it. It just shows it's mediating it if it's not shut off. Okay, so inappropriately normal is another concept that we oftentimes talk about. Okay, next case. 22-year-old Caucasian female comes in after a motor vehicle accident, broke her thumb. She lost consciousness during cast placement. Her blood pressure was 75 over palp. She was tachycardic. You gave her saline. She's doing better. Vitals normalized. Her temperature shows she's afebrile. She's thin. She's tan. She's got vitiligo. Other medical conditions include hypothyroidism and celiac disease. Her basic labs show a little bit low sodium, a little bit elevated potassium. Glucose is 61. TSH is normal. You got a head CT, and that was normal. Which of the following is the most appropriate next step in her care? Hydrocortisone plus fludrocortisone and order an ACTH stimulation test, or give her Dex and order your ACTH stimulation test. Good. The answer is C. So they know you know it's adrenal insufficiency at this point, right? And what they're trying to figure out is, do you just go ahead and empirically treat, or do you treat and try to get a diagnosis? If you were to give hydrocortisone, and that wouldn't be wrong necessarily, you would treat the person, but you wouldn't get a diagnosis, and that's what we're looking for. She's hemodynamically stable, so we have the luxury of being able to get a diagnosis. Hydrocortisone and fludrocortisone, if you were to give hydrocortisone, you cannot do an ACTH stimulation test. Hydrocortisone is measured in your cortisol assay. Okay, so the moment you obligate someone to hydrocortisone, you will not be able to get the diagnosis that day. You'll have to wait to the next day if you want to order an ACTH stimulation test and look for your cortisol to go up. So the right answer here, or the best answer here, would be to give Dex, because Dex does not interfere with your cortisol assay. It's not measured in your assay. You order your ACTH stimulation test, so that way she's empirically treated, and you're going to get your answer as to the etiology of the adrenal insufficiency. So for her, most likely scenario would be primary adrenal insufficiency, which is adrenal failure, which is autoimmune, which is high ACTH levels. You will see secondary adrenal insufficiency in practice. And again, the most common scenario of that is abrupt withdrawal of chronic exogenous glucocorticoids. In this scenario, because your glucocorticoids shut off your entire axis, it will be a low ACTH state. Common symptoms are weakness and fatigue, anorexia, abdominal pain, hypercalcemia, and when it does present acutely, it is an endocrine emergency. So when we talk about primary adrenal insufficiency, in this country, the most common etiology is Addison's disease, which is autoimmune. In other countries, you can still have infectious diseases as a common etiology of primary adrenal insufficiency. Because of the high ACTH levels, you get hyperpigmentation, and because it is chronic destruction of the adrenal cortex, you lose all three hormones. You lose cortisol, you lose mineralocorticoids, and you lose DHEAS levels. Because you lose aldosterone levels, you lose the ability to handle blood pressure and potassium. And so it's only in the context of primary adrenal insufficiency where you lose aldosterone production that you will have the hyponatremia, the hyperkalemia. It'll be a high renin state. And this is the scenario you want to supplement with fludrocortisone. And it's not that your glucocorticoids don't have mineralocorticoid activity, but to get to the level of mineralocorticoid activity with the glucocorticoids we use, you have to use such high levels that we rather just add on the fludro in order to get the control that we need. The diagnosis of adrenal insufficiency comes after an ACTH stimulation test. It can be done any time of day because we are using such a high dose of ACTH. It's so super physiologic. And what we're looking for is a stimulated cortisol greater than 18 or 20. The treatment acutely is going to be dexamethasone or high-dose hydrocortisone. You do not need fludro in this acute term because, again, we use such a high dose, it will give us our mineralocorticoids. Chronic care includes giving glucocorticoids plus the mineralocorticoids. In secondary adrenal insufficiency, again, the most common scenario, the most common etiology is chronic exogenous glucocorticoids. You could come from pituitary disease like pituitary surgery or pituitary trauma. Generally, this is a low ACTH state, so you don't get the hyperpigmentation. Because if you recall, I had told you that aldosterone is more tightly regulated by the renin system, you do not lose aldosterone production. So even though you don't have ACTH manipulating it a little bit, you still have your renin system intact, which will drive your aldosterone production when needed. So generally, potassium is normal. And again, how we want to diagnose this is an ACTH stimulation test. But there is a pitfall to this testing. When you have recent pituitary trauma, recent pituitary surgery, if you were to do an ACTH stimulation test, it is very likely that the adrenal glands will still respond because you have not given the adrenals enough time to atrophy. So it's only in long-standing ACTH suppression or in long-standing disease where you've had adequate time for the adrenals to atrophy that you will fail an ACTH stimulation test. So in this context, it might be more prudent to get an 8 a.m. cortisol because if your 8 a.m. cortisol is less than 3, that highly suggests adrenal insufficiency. If it's greater than 12, you essentially have ruled it out. Once you do diagnose secondary adrenal insufficiency, it would be prudent to image the pituitary to see what is going on, to find out the etiology. And again, acute is high-dose steroids, chronic high-dose steroids. You do not need mineralocorticoids because you still have your renin system that's intact. It is important to remember that autoimmune diseases run together. This is a concept I saw both on internal medicine and endocrinology boards. So when you have someone with adrenal insufficiency, you're thinking hypothyroidism. When you have someone with diabetes, you're thinking celiac disease. So you want to think what diseases can coexist. And you also want to think about it in the context of if you diagnose hypothyroidism, you want to look for adrenal insufficiency in these people because given thyroid hormone can precipitate adrenal insufficiency or unmask it. 53-year-old with poorly controlled hypertension on 5 blood pressure meds, including an ACE inhibitor. In normal BMI, no bruit. Sodium is 142, potassium's a little bit low at 3.5, bicarb on the high normal side, creatinine is normal. What is the next best step in his management? Renal angiogram, random cortisol, check serum renin and aldo level, or add an ARB to his ACE inhibitor regimen, which he's on? So C, correct. So this person is on a very robust regimen of more than 5 medications, certainly needs a secondary evaluation. Now remember, we would only do a renal angiogram if it is proven renin-mediated aldosterone excess, right? We don't have that data at this point. Random cortisol levels, rarely useful. And we would not ever add an ARB to an ACE regimen because data shows that there's actually worse outcomes. And so our job at this point is to evaluate for secondary hypertension, including aldosterone excess. So we want to pair a renin and aldosterone level and see what that looks like. And again, we never image without a diagnosis in these patients. So what we're describing here is primary hyperaldosteronism. The causes can be single adrenal adenoma, Conn's disease, or bilateral adrenal hyperplasia. Key features are generally hypertension, hypokalemia, although it doesn't necessarily need to be present, and metabolic alkalosis. Screen, confirm, localize. Never image without a diagnosis. So how we're going to screen for it is we're going to check simultaneous levels of plasma aldo and renin. It should be a high aldo state, suppressed renin, therefore giving you an elevated ratio. We want to do confirmatory testing, so we want a high salt load. So we can either do a saline infusion or put people on a high salt diet for 3 days and then see what that does to their aldosterone levels. Once we have confirmed that we have an aldosterone excess state, then we want to image the adrenal glands. We might consider adrenal venous sampling depending on the age of the person and what the presentation looks like, but that's kind of beyond the context of where we are now. But we want to image the adrenals and then consider adrenal venous sampling plus or minus surgery. Remember that medical management is as good as surgical management. So if there's ever the question of it, is it unilateral or bilateral disease, medical management will be just as good as long as you use aldosterone antagonist therapy with spironolactone. And so what is the treatment? If they're an adenoma and they're young, surgical resection. We can cure the hypokalemia the majority of the time. And generally when you find it in young people, you will cure the hypertension. When you find it in someone older after they've had long-standing hypertension, you will probably fix the hypokalemia, but it is not uncommon that the hypertension will persist. It will not be as bad as the hypertension before, but we want to have realistic expectations of what will happen when it's diagnosed in older people. If there's adrenal hyperplasia, we want to use medical management with aldosterone agonists. And remember, medical therapy is also an option for adenomas if the person is not a surgical candidate. Next question, 46-year-old woman with FEO scheduled for resection. What is the best initial method for managing her blood pressure? Pre-op. Propranolol, hydrochlorothiazide, metoprolol, terazosin, or lisinopril? The answer is D. So you got to remember in FEO that alpha blocker is the gold standard, right? Because you want to block the catecholamines and metanephrines. Beta blockers can precipitate a crisis, so you want to avoid beta blockers in all FEO that are not adequately alpha blocked. These patients are dry, so we would not use a diuretic. So alpha blockade is the treatment of choice. And again, FEO, rare in practice, just like acromegaly, but common on boards because they want you to be thinking about these rare diseases in order not to miss it. Clinical presentation, generally hypertension, either episodic or sustained, with the triad of sweating, palpitations, headache. You can also get nausea, pallor, and anxiety with it. So we want to screen initially, and when we have a high pretest probability, like family history or adrenal adenoma that's very vascular, we want to do plasma metanephrines. Plasma metanephrines is better than urine metanephrines because we will miss less, but we have a higher false positive. When you have a low pretest probability, you want to do urine metanephrines. Once we have a positive screen, we want to confirm. So we want to do a clonidine suppression test. And once we are convinced that we have a FEO, then we will localize. We never image without a diagnosis because we wouldn't even know where to look. We got to make sure that we have the actual diagnosis. And so not all FEOs are the same. Some are bilateral, some are malignant, some are extraadrenal, called paraganglioma. Some are asymptomatic. It's always important to remember that there can be a genetic component. So in younger people, bilateral disease, extra-adrenal malignant, we are always thinking genetic evaluations. And always alpha block is first line, never beta block. Next question. 63-year-old man was having abdominal pain. You suspected kidney stones. It was negative, but now you have a 2-centimeter left adrenal adenoma. He does not have high blood pressure or diabetes. His BMI is overweight at 26. Blood pressure is 120/77, heart rate's 80. He has a normal TSH and CMP. Which of the following is the next best step in this patient's care? Check a 1 milligram overnight dexamethasone and urine metanephrines. Check a 1 milligram overnight dexamethasone, urine metanephrines, and screen for aldosterone excess. Reassurance, send to your surgical colleagues, or check a 24-hour urine-free cortisol and 17 keto steroids. So the answer is A. So let's talk about that. So what we're describing here is an adrenal incidentalloma. We talked about pituitary incidentalloma, we talked about thyroid nodules being common. Now we have an adrenal incidentalloma, common. So for all adrenal incidentallomas, you want to ask, are they functional or are they cancer? So everybody gets a functional evaluation for adrenal adenomas. Everybody gets ruled out for cortisol excess as well as for FeO. Cortisol excess is the most common, FeO is the scariest. You only need to add on aldosterone excess evaluation in the context of hypertension or unexplained hypokalemia. Reassurance is never the right answer until you are assured that they have a normal hormonal evaluation. The hormonal evaluation happens yearly for a few years. Surgery only happens if it's functional or it's large. And we would only check a 24-hour urine for keto steroids if we suspected ACC, adrenal cortical carcinoma, because oftentimes these tumors are inefficient at making end products. So we check their precursor products, which are the 17 keto steroids. So again, the definition of an adrenal incidentalloma is a mass larger than a centimeter discovered by accident on imaging study. It is more common as you get older. Up to 5% of older people have adrenal adenomas. 2 questions. Is it making hormones or is it cancer? You think of cancer when it's greater than 4 centimeters in size. So that's why generally 4 to 6 centimeters will get you surgery independent of whether it's functional or not. So about 10% of the incidentalomas secrete hormones. So what you want to do is check for this hormonal excess. And again, FeO for everybody, although it's very rare, but it's the scariest and you don't want to miss it. Cushing's for everybody because it's the most common. And if the initial evaluation is negative, they get screened for cortisol excess for the next 3 or 4 years. You want to consider testing for aldosterone excess in the context of diagnosed hypertension or hypokalemia. If you find that it's non-functional, you want to repeat the imaging once to make sure it's not growing. That's generally 6 to 12 months after. You're going to repeat hormonal testing for a few years for cortisol excess. And again, they'll get surgery if it's large, increasing in size, or if it's functional. Remember, if it's making aldosterone, you'll have the option of surgery versus medical management. Okay, next question. A 60-year-old man who presents with a 30-pound weight gain over the past 2 to 3 years, hypertension, abdominal striae, and compression fracture. 1 milligram dexamethasone suppression test was a fail. He should have been down to less than 1.8, but his cortisol was 8. 24 urine cortisol was also elevated, almost double, and his ACTH was mildly elevated at 60. Which of the following is the most likely cause of cortisol excess? Pituitary adenoma, adrenal adenoma, ectopic ACTH, or prednisone use? A is correct. This is Cushing's disease. So we know that it is ACTH mediated. So really your differential is pituitary adenoma versus ectopic. Hands down, the more common scenario for ACTH mediated cortisol excess would be pituitary-based disease. In ectopic, generally the ACTH levels are higher, you get hypokalemia, the symptoms occur much faster, and it's generally in the context of a known malignancy. It's not a surprise. Versus adrenal adenoma would be a low ACTH, and any sort of exogenous steroid use, except for hydrocortisone, would be a low ACTH state, okay? So to get you oriented again, we're going to be talking about the anterior pituitary, making the hormones FSH and LH under response of GnRH. The FSH and LH jobs are to go to either the ovaries or the testes in order to make sex hormones and to mature the gametes, so for the sperm and the ovarian maturation. And then it's the sex hormones that are going to feed back on the hypothalamus and anterior pituitary to shut off GnRH and LH and FSH production. So get to start off with a question again. Perfect timing. 36-year-old woman with amenorrhea for 4 months, interested in fertility. On exam, there's thin white fluid expressed from each breast. Prolactin level is 40, which is elevated. Beta HCG is negative. TSH is normal. And on imaging, you see a 6 millimeter pituitary mass. Which of the following is the next best step in management? Refer her to a neurosurgeon, start cabergoline, or observation and recheck prolactin level in 6 to 12 months. B. B is the correct answer. We want to start dopamine agonist therapy. So prolactinomas is what she has. It's medically managed, exquisitely sensitive to dopamine agonist therapy. We would only refer her to a neurosurgeon if she did not tolerate the medication, and we need to have this fixed. Remember, no neurosurgeon out there is going to be excited to touch a woman of reproductive age, because you really worry that if you start touching the pituitary, then you will lose the ability to make sex hormones and ovulate. And so again, you lose first what you need least when you start talking about pituitary disorders. So the restoration of fertility is generally never in the hands of a surgeon for prolactinoma. And again, observation would not be unreasonable if fertility wasn't the end game. Because if she's estrogen deficient, wasn't interested in fertility, not bothered by the galactorrhea, she could start birth control. And we could just watch and see what the prolactinoma does. But since she is interested in fertility, or if she were interested in fixing the galactorrhea, the only way to fix both of those would be to normalize the prolactin level. So dopamine agonist therapy is what is necessary. So secondary amenorrhea is the absence of periods for 3 cycles or 6 months. So this is a little bit different than the terminology that we talked about. Primary amenorrhea is never had a period, right? But primary hypogonadism is either testicular failure or ovarian failure. So just think about it that way. So we're not talking about the gonadal failure, we're talking about never having a period. So this is secondary amenorrhea. So I had a period at least once, and now I don't have periods going further. We want to test all women for pregnancy. We want to consider premature ovarian failure, right? That's primary ovarian failure, where we have a very high FSH level in the menopausal range. PCOS, which is probably the most common cause of secondary amenorrhea. And here you get the metabolic abnormalities of obesity, fatty liver, sleep apnea, dyslipidemia, as well as signs and symptoms of androgen excess. There could be hypothalamic amenorrhea. So these are the people that have anorexia or the excessive exercisers where there's a deficit of calories. And again, sex hormones are luxury hormones. If you don't have enough calories, you will not make your luxury hormones, because you're going to be using that cholesterol to make what you need to live, which is your cortisol and thyroid hormone. Androgen excess, outside of the context of PCOS, we're talking about ovarian tumors, adrenal tumors, congenital adrenal hyperplasia, prolactin excess, and primary hypothyroidism. So that's failure of your thyroid, most common etiology, Hashimoto's. And here you're going to see that the hypothyroidism causes hyperprolactinemia, which then will shut off sex hormone production. So lab evaluation, we test everybody for pregnancy, we check FSH, TSH, and prolactin levels. If all is normal, we do a progesterone challenge. So it's the estrogen that builds up the lining, progesterone maintains it. So if you were to give someone progesterone for 5 or 10 days and they have a withdrawal bleed, they are making estrogen. That is not an estrogen deficient state. If you give them progesterone for 5 to 10 days and they do not have a withdrawal bleed, that is a low estrogen state. So in this context, with absence of estrogen, meaning you're not having a bleed after progesterone, with normal gonadotropes, inappropriately normal LH and FSH, you want to then image the pituitary to make sure that you're not missing anything at the level of the pituitary. But again, your diagnosis, your differential would be hypothalamic amenorrhea or pituitary tumor. So let's talk about PCOS, the most common etiology of secondary amenorrhea, and is also the most common etiology of hirsutism or signs of androgen excess. Generally requires 2 of the following. We look for ovulatory dysfunction, either not having periods or having irregular periods. We're looking for laboratory or clinical evidence of hyperandrogenism. So sometimes you see a high testosterone, sometimes you see a normal testosterone, but clearly you have increased terminal hair, you have acne, you have scalp hair loss, so signs of androgen excess. And sometimes you look for ultrasound evidence of PCOS. That's more done by the OBGYN, so generally our diagnosis requires the first 2. Plus, we want to rule out other causes that can mimic PCOS. Now remember, PCOS is generally of a long duration. People generally come in with 5-10 years worth of the same symptoms. So the yield of doing this secondary evaluation is kind of low. So you really want to be thinking about focusing this secondary evaluation on changes, that they didn't have this from the start of their periods. This has generally been happening for 1 or 2 years, or the signs of virilization. Because the difference between hyperandrogenism and virilization is the amount of androgens they are seeing. So generally with PCOS, it's an androgen high state, but you don't see overt virilization where you have increased muscle mass, deepening of the voice, clitoral enlargement, profound scalp hair loss. That is truly the time that you take a step back and say, okay, this is not what we're used to. We need to make sure we're not ruling out other causes, including androgen secreting tumors, like checking a DHEAS level. Think about an adrenal tumor, testosterone being sky high, ovarian tumor, 7-hydroxyprogesterone being elevated like in CAH, or cortisol excess. So a premature ovarian failure is when you hit menopause before the age of 40. Because remember, the average age of menopause in the United States is early 50s. Here it's the context of signs and symptoms of estrogen deficiency, hot flashes, vaginal dryness, no periods, in the context of an FSH that's elevated in the menopausal range. Whenever you diagnose premature ovarian failure before the age of 40, you do want to consider sending out a karyotype for Turner's, because if Turner's is diagnosed, we do have other things that we need to do to care for this patient. You can also consider an evaluation for Fragile X, but that doesn't have any other evaluation that needs to be done if they are diagnosed as a carrier. And the treatment is to target bone health and overall quality of life, and generally the mainstay of treatment is estrogen. So we talk about hypogonadism in men. We're talking about symptoms of poor libido, hot flashes, decreased motivation, erectile dysfunction, gynecomastia, decreased morning erections. As a purist and as a board taker, we require overtly low testosterone to diagnose this. That means 2 8 a.m. cortisols less than the lower limit of normal for that assay. So generally 200 or 300, depending on what that assay is. So on the boards, they do not want you treating those patients, which we see every day in practice, with the low normal testosterone and normal LH and FSH level, okay? So who warrants therapy with regards to testosterone replacement are those men who truly have a low testosterone level on the labs. If testosterone is shown to be low, then we want to measure LH, FSH, and prolactin levels. If the LH and FSH are high, we're looking at primary hypogonadism or testicular failure. And if the person's younger and they have characteristics, wingspan, tall, gynecomastia, we're thinking Klinefelter, so it'd be prudent to evaluate for that. If the LH and FSH are normal or low in the context of a low testosterone, we are thinking secondary or pituitary-based hypogonadism. It's very important to know that chronic opioid use is a very common cause of acquired hypogonadism. It is a standard of care for people on long-term opioids to screen for hypogonadism. It can also cause adrenal insufficiency. And chronic glucocorticoid use can also cause hypogonadism. Again, measure the prolactin, consider iron studies, hemochromatosis. You can see secondary hypogonadism, consider a pituitary MRI, and screen for obstructive sleep apnea. And this is going to be more in the wheelhouse of what I said is common. So generally what we're seeing in our clinic, if testosterone assay is 200, we're seeing the guys at 250, LH and FSH are 3 and 4. So around that area. And here's where you want to think obesity, obstructive sleep apnea. Both of those have been implicated in hypogonadism or relative hypogonadism or subclinical hypogonadism. And the name of the game there is to treat the sleep apnea, to treat the obesity, and to see if the testosterone improves. But again, generally these patients do not have overt low testosterone. It's just low normal. And they'll say, well, I'd really like my testosterone not to be 250. If normal is 200 to 1,000, I'd like to be 800 or 900. And that's where you take a step back and say, well, there's no guidelines that are going to support treating a testosterone that's in the normal range. We're going to try to influence other things that can influence your testosterone levels, including the sleep apnea and obesity. Anabolic steroids. These patients will seek care, often being pushed by their other half for infertility, and sometimes they will get to you for gynecomastia. Now, again, it's rare that I see gynecomastia in these patients because generally these patients have such a sophisticated regimen. They know how to prevent the gynecomastia. They know how to prevent the testicular atrophy. They know more about restoring their gonadal access than any of my fellows know about the gonadal access. And what you're looking for is muscular hypertrophy, acne, testicular atrophy, if it happens. But again, I'm telling you, we don't see it that often because they know how to give themselves HMG, HCG, Clomid. They are all over it. Generally, the LH and FSH levels are very low because the testosterone that they're using is often in much higher levels than we would ever use it, so it shuts off pituitary. You're going to see variable testosterone levels, and that's because, one, it's injectable, so it can be anything, and two, sometimes the testosterone that they're using is not going to be able to be measured in our assay because there's different kind of testosterone formulations and preparations that can be used, and some are measurable and some are not. These patients are generally very difficult to treat because you will never feel as good as you feel on super high doses of testosterone. So even when I normalize you or make it physiologic, you're not going to like me. And these regimens are very, sophisticated, so it's hard to know exactly at what point do you interject, what is the right thing to do. And so your job on the boards are just to recognize these patients and not to treat these patients, but recognize that something's going on. For example, they might come in and the testosterone might be undetectable. Well, as it turns out, the reason why it's undetectable is because they're using something that you cannot measure in your assay. So they're using other anabolics along the way. Okay, next question. A 36-year-old person assigned female at birth presents stating he wants to start testosterone. He has identified as being a man since childhood. He is dressed in male clothes, he is binding his breasts, and he's accompanied by his female partner. He does have a letter from his therapist who is also treating his anxiety. What best describes this patient? Gay, gender dysphoria, gender identity disorder, or bipolar? The answer is B. Okay, so let's talk a little bit about terminology. So this person is heterosexual. Remember, gender identity is how we identify ourselves. Are we male, female, neither, both? Sexual orientation is who we are attracted to. One has to do nothing with the other. So this person is heterosexual. Gender dysphoria is the right terminology as of 2013. Before 2013, gender identity disorder would have been the right terminology, but now it is gender dysphoria, and clearly not bipolar. It is going to be important to know the terminology because you will see these patients along the way in your practice. So again, part of the terminology, transgender. These are people who were assigned a gender at birth, and rightly so. Everything said that they should be this gender. From chromosomes to hormones to internal, external anatomy, they were assigned. But somewhere along the way, as they acquired their gender identity, they now don't agree with what they were assigned at birth. And again, it could be the opposite, it could be somewhere along the spectrum, but they are not who they were assigned. Gender dysphoria is the anxiety or depression or distress that comes along with being transgender. And currently, that is the most up-to-date diagnosis that we have for these patients. Unfortunately, it's not a medical diagnosis, it's a psychiatric diagnosis, so the push out there for we who do this and care for these patients is to actually get a medical diagnosis when ICD-11 comes along, and we'd like for that to be gender incongruence. But as of now, the latest terminology is gender dysphoria. And again, not related to sexual orientation. So if you want to know who your patients are sexually active with, you need to ask. All right, now we are going to go on and start talking about lipids and then go into diabetes and calcium. So when we talk about lipids, what you're going to find are there plenty of viewpoints and guidelines to consider. And we are clearly not going to go through all of these because all have their little nuances and all are still evolving. But there are some common themes that you'll see, and there are some common patients that all these guidelines feel that would benefit from treatment. And we specifically are talking about treatment. We're going to be talking about statin benefit groups along the way. So it is going to be your job to recognize which patients are going to be treated with lifestyle versus which patients are going to be treated with lifestyle plus statins. We'll talk about the other medications that we have to treat dyslipidemias. But what you're going to hear from me is none of those other medications have the cardiovascular outcomes that statin has. So at the end of the day, if it's a statin benefit patient, independent of what lipid profile they give you, low HDL, high triglycerides, you're going to give a statin and nothing else along the way as first line of treatment on boards. So lipid basics. Lipid facts are hard to remember. They change very little day to day except for triglycerides. And high triglycerides can actually influence your measurement of your lipids because if the triglycerides are greater than 400, then the LDL is inaccurate. And again, statins are going to be indicated for most high-risk patients for cardiovascular morbidity and mortality. So cholesterol is required for the synthesis. LDL is cholesterol It provides for the synthesis of hormones. Lp(a) is an independent risk factor for coronary heart disease and stroke. But targeted treatment does not modify risk. Do y'all know what will decrease Lp(a)? Niacin, exactly. So the answer on the boards is never to check it and never to treat it if it is checked because we don't have outcomes that make a difference, okay? But yes, in practice, niacin would be a very good treatment option. And LDL receptors are upregulated, leading to lower LDL levels in certain situations. So it's when your diet is healthier, when you start estrogen is protective, when you start thyroid hormone, when you are hypothyroid, by the statins, and with decreased bile acid uptake from the intestines. HDL is good. We raise it with exercise, alcohol, diet, niacin. It scavenges the unesterified cholesterol. When you have a very low level, we know that we have premature heart disease. But there's no good data to solely target low HDL levels from an outcome/board standpoint, and that's what we're teaching to today. So again, in practice, if you have a statin benefit person, even if their LDL is fine at 80, and their HDL is 13, your job is to put a statin on board rather than chasing the HDL where we don't have great outcomes data, okay? And again, I'm an endocrinologist, so endocrinology boards would probably be very much heavier in lipids than yours would be. But that was always the carrot that they were dangling, trying to give you these crazy lipid profiles. And clearly at the end of the day is, are they statin benefit or not statin benefit group? And then trying to figure out who you're going to give a statin to. So lipid screening should start at the age of 20. And the reason why you're starting off so young is because you're looking for familial dyslipidemia and secondary causes, things that are reversible, nephrotic syndrome, medications, hypothyroidism. And then you want to assess other risk factors every 4 to 6 years. So you want to look at the cholesterol, you want to look at blood pressure, screen for diabetes, assess the smoking status, because you want to keep people healthy. It's so much easier preventing disease than it is treating disease. And then at the age of 40 is when you want to start doing a calculation. You want to calculate their 10-year risk to determine if they are going to benefit from a statin. So again, part of the statin benefit group. And we choose the age of 40 because in less than 40, we worry about women of childbearing age. And so you really don't want to offer many people less than 40 statins, especially if they're women. And especially when you know that when you're starting less than 40, we're going to have many, many, many years of therapy. So again, do not measure lipoprotein little a, apolipoprotein B, or homocysteine levels on the boards because the treatment has no impact on mortality. So what are our risk factors for cardiovascular disease? Again, a big one is LDL. That's why we're talking about it. Whenever someone has a risk equivalent, even if they don't have named cardiovascular disease, if they have these diseases, they are considered to have cardiovascular disease and we need to treat them aggressively. They include diabetes, peripheral artery disease, stroke, history of stroke, and aneurysm. So what are some non-LDL risk factors for cardiovascular disease? Age. We know that as you get older, the risk increases. Family history of early heart disease, smoking, hypertension, or on treatment for hypertension, and a low HDL. Now, that being said, a good high HDL is a negative risk factor. So we would like to push up that HDL in patients, but again, never the right answer if they have cardiovascular disease or risk equivalent. So why treat dyslipidemias? Why use statins? Because there's really good data out there in primary prevention, which is preventing the first event, even in those without cardiovascular disease. And there's even better secondary prevention data out there. So in people who've already had their first event, they are at very high risk for further events. And there's excellent data that statins will help decrease the secondary events that happen after the primary ones. And there's event data and mortality data showing that statins are really good medication. What are some statin principles? The higher the cardiovascular risk, the greater the benefit with the statins. That's why secondary prevention, there's more data than primary prevention. The higher the dose, the greater the benefit. The higher the dose, the higher the harm. On boards, always the right treatment for those with high cardiovascular risk, even if the LDL is not very high, is a statin. So a statin benefit should get a statin, even if the labs look fine. Okay, 47-year-old healthy man has the following lipid values after a 6-month program of diet and exercise. Total cholesterol is 230, LDL is 175, HDL is 45, triglycerides are elevated 320. Because he's older than the age of 40, we calculated his risk, and his 10-year risk estimate is 4%. In addition to continued diet and exercise, which of the following would you recommend? Start a statin with an LDL goal less than 60. Start a statin with an LDL goal less than 130. Initiate a fenofibric acid with a goal of less than 150 for triglycerides. Start niacin or no additional treatment. The answer is E, no additional treatment. So those of you who answered with the target of less than 130 were still the treat to target group, and those were the older guidelines. So the guidelines that we're talking about with the statin benefit kind of trumped those. So no longer do we have the concept of treat to target. We have the concept, are you statin benefit or not statin benefit? Okay. Fibrate will decrease triglycerides, but no outcomes data. So sometimes when they try to throw those things at you, with giving you a triglyceride level of 300 or 400, try to make you do that. But the truth is either there's statin benefit or they're not. And so these are the guidelines that we're talking about, the 2013 guidelines, where there's an emphasis on treatment with statin medications based on level of risk. So no longer are we looking at LDL goals and targets, no longer treat to target. It's will you benefit or not from a statin? And the 4 target groups are known cardiovascular disease or its equivalents, diabetics over the age of 40, if you have a high LDL greater than 190, and again, you should be evaluating for secondary causes to make sure that we're not missing secondary causes of high LDL before you treat. And then those without cardiovascular disease or diabetes who have a 10-year risk greater than or equal to 7.5%. That's why at the age of 40, we're going to start doing calculations of what someone's risk is. So known cardiovascular disease, diabetes over 40, or a markedly elevated LDL, or a high risk based on risk factors would be statin benefit. A 73-year-old obese woman with diabetes has the following lipid values. LDL's 98, HDL's 39, triglycerides 470. In addition to lifestyle modification, which of the following would you recommend? Start a fibrate to target triglycerides, follow her lipid panel, and initiate a statin therapy if her LDL goes above 100. Initiate moderate intensity statin without a specific goal, or use niacin. Good. I said it enough. So statin benefit group. She is one of those because of diabetes. So she's got moderate risk, so she gets a moderate dose statin. And again, the reason why this LDL of 100 is no longer the trigger is because we no longer use treat to target. I know that we'd all be excited about getting down those triglycerides because we worry at greater than 500 it increases the risk of pancreatitis. But again, that's not the name of this game. The name of this game is cardiovascular disease, and a statin will get us there. When we talk about the intensity of a statin, we're talking about moderate or high intensity. The moderate will drop the amount by a moderate amount. The high will drop it by a higher amount. And those are kind of an idea of what the doses are that correlate with each. So who should get the high intensity statin? These are the high risk patients. These are the patients that we would expect disease to happen in a shorter amount of time. So it's all people with known disease. Have a high HDL where you need a high dose statin in order to get that 50% reduction to make the LDL reasonable. It's the people with diabetes, which is considered a risk equivalent, who also has other risk factors so that their calculated risk is above or equal to 7.5%. And it's essentially at the end of the day, the high intensity is for super high risk or super high LDL levels. So who should get the moderate intensity statin? Well, these are the people with cardiovascular risk equivalent like diabetes, whose 10-year risk is less than 7.5%. Or it's for the ones that primary prevention, so they don't have known heart disease, they don't have diabetes or an equivalent, but you calculated their risk and it's equal to or greater than 7.5%. These are the ones that you should consider moderate intensity statin therapy. So I keep saying diabetes is a risk equivalent. Where did we get this data from? So they did this study in 1998. We all know that people who've had a heart attack have a much higher chance of getting subsequent heart attacks and have increased risk of mortality. And what they did was they looked at patients who had diabetes without a heart attack, and they looked at people who did not have diabetes but did have a heart attack. So these are the cardiovascular patients, and what they saw was that mortality was the same whether you had diabetes without a heart attack or you had a heart attack without diabetes, which then made them equivalent. So you're not doing great if you have either a heart attack or diabetes. In the context where you have diabetes and a heart attack in the past, the survival was even worse for that, okay? So that's where we're getting the data that having diabetes alone is equivalent to having known cardiovascular disease. It was from this study. And that's why diabetes gets lumped on with established cardiovascular disease because of this data that we have. So what are the treatment strategies? Well, lifestyle modification is a must for everybody. But no longer will you see it as an answer that's suitable for the statin benefit groups. So lifestyle modification, diet and exercise is always awesome. Throw it at people. In the past, you might have been able to put it on as sole therapy for people like diabetes, who had diabetes if their LDL was low, but no longer. The moment you determine someone is statin benefit group, you're adding on a statin in addition to diet and exercise. Okay, and so when we talk about the medications, we're going to talk about statins and then everything else. So with statins, we have decreased mortality in primary and secondary prevention, both all-cause and cardiovascular, decreased risk of MI, stroke, and decreased complications with revascularization procedures. Now, statins are not perfect. You can see elevations in liver enzymes, you can see myalgias, rhabdo, and there is a real increased risk of diabetes. Now, it's not enough to avoid these medicines in those who we feel would benefit, but it is something to be aware of, and it is real, this excess diabetes risk. Statins do not combine well with certain medications, so you have to be aware of interactions. And again, we worry about using them in women less than the age of 40 because we worry about pregnancy risk. So monitoring. There is no need per insert to increase the risk of monitoring that we do. There's no need to check liver enzymes automatically or CK levels, that it's the clinical context that should direct whether we are going to do labs. But in truth, any of us who are following these patients long term, we're getting these labs anyway, at least lipid tests and screening for diabetes as part of routine care. But again, no need to do it simply because they are on a statin. Okay, statins have randomized controlled trials showing cardiovascular benefits for which of the following groups? Dialysis patients, diabetics without heart disease, age over 80, all of the above. B is the right answer. There's no data on dialysis patients. And, you know, I wouldn't say that you should avoid statins, but it's going to be one of those groups that we just don't have enough data to say that when they're on dialysis, they still need statin therapy. We don't have a lot of great studies that include people over 80 years old. So that's just limitations of the studies that we have out there. And so of those, the only one that was proven statin benefit group is diabetes without known coronary artery disease. What if my patient can't tolerate a statin? Try again. There's no excuses to not try to put statins on board. And patients are resistant. You know, once they've had those myalgias, they generally don't want to go back. And so that's why we say, okay, look, try it one more time, see if you tolerate it. If you don't tolerate it, let's try a different statin, maybe one associated with less myalgias. If you don't tolerate that, can we try getting you to take it a few times a week? Because even a few times a week is better than no times a week. So we really want to get those statins on. That's how much we've bought into this statin principle, okay, that we will take even a handful times a week in order to try to get that statin on board. So let's talk a little bit about non-statin therapy. Ezetimibe inhibits intestinal cholesterol absorption, reduces LDL alone or in combination with statins. They're not perfect, but the profile, people generally tolerate it very well. 45-year-old healthy man has a routine check of his lipids. Total cholesterol is 198, LDL is 125, HDL is 35, triglycerides 460. His 10-year risk is 4%. And again, we calculated that because he's over the age of 40. Which of the following is the next best step? Diet and exercise, a fibrate, a bile acid sequestrant, ezetimibe, or niacin? Yes. On boards, if not statin benefit, you'd get diet and exercise alone. If a statin benefit, you get diet, exercise, and a statin. Okay. And so let's talk about it again. We talked about ezetimibe. Again, never will be your first line answer if there's statin benefit. Fibrates have some data out there where they decrease triglycerides and raise HDL levels. There have been studies out there that show fibrates will have cardiovascular benefit, but the pushback you're going to hear, and the reason why we wouldn't choose to target this first, is because generally when you have these studies that look at fibrates or niacin, it's versus placebo in high risk. So you're not going to find where these other medicines trump statins with regard to the data for cardiovascular protection. So it's not that there's zero data, it's just that the data is not enough to say you should use this over statins because the studies have been against placebo. And you would say, well, what about add-on? Well, Accord showed us that the addition of a fibrate to a statin did not have the effects that we were looking for, did not show cardiovascular protection. So we don't have that support either from the Accord. So again, if there's statin benefit, even if they have high triglycerides, they get a statin. And do keep in mind, should you choose in clinical practice to add on a statin and a fibrate together, that the myopathy risk increases. Niacin will raise HDL, lower triglycerides, lower Lp(a), which we talked about, which we like. But again, not a good reason to order or treat on boards. Side effects, flushing, that could be diminished by taking aspirin 30 minutes prior. And again, it does have some side effects, but never the right answer to target HDL alone if it's a statin benefit group. Bile acid sequestrants block reabsorption of bile acids, thus lowering LDL levels. Again, there are some studies out there that shows that it reduces cardiovascular disease. But again, this study was against placebo, okay, not against statin. So statin has the best data out there. It's safe for use in combination with statins. So suppose you have someone in clinical practice, the boards are not going to ask you this, in clinical practice where you'd like the LDL just a little bit lower, and gosh, they have diabetes, wouldn't it be great if I can just decrease that a little bit? Well, there are some that will lower A1C a tiny bit, as well as lower LDL levels, so that might be a good add-on therapy in practice. But again, board's never going to be the right answer. And do keep in mind when you do use bile acid sequestrants, constipation and high triglyceride levels are side effects of it. A healthy 32-year-old woman comes in for a routine checkup. She's a non-smoker, no family history of heart disease or diabetes. She exercises and eats a heart-healthy diet. Her total cholesterol is 285. Her LDL is elevated at 210. Her HDL is a little bit low at 35. Her triglycerides are 180. What is the most appropriate next step in her management? Moderate intensity statin, high intensity statin, fish oil, lifestyle changes, or do an evaluation including a metabolic panel, TSH, UA, and pregnancy test? Excellent. The answer is E. She's young. That's why we're screening to look for secondary causes and familial causes. We absolutely want to make sure that there's no secondary reason for her markedly elevated LDL levels. So we're looking for nephrotic syndrome, hypothyroidism, and pregnancy as an etiology, something reversible that we can address along the way before we ever think about instituting a statin. And again, even if she were statin benefit group because her LDL was above 190 and we didn't find any other risk factors, we still have to talk to her about pregnancy and what her plans are there, because we would want to be very cautious before we put on a statin in someone of childbearing age. So again, don't forget the secondary causes because we can fix those. So what are the areas of uncertainty? In primary prevention, it's those that are young or those that have risk, but the risk is low cardiovascular risk. In secondary prevention, you're not going to find data that it's end-stage heart failure, end-stage renal disease. And overall, a lot of our studies have men in it who are of younger age and predominantly white. So like many studies out there, we don't have a lot of great data representing our entire population. All right, let's now switch gears to diabetes. I got 2 slides on the classifications of diabetes. So type 1 diabetes is beta cell destruction, autoimmune. We typically think of type 1 in those that are diagnosed younger, ones that are thin, have other autoimmune diseases. Type 2, hands down the most common type of diabetes we're going to see, is a disease of insulin resistance and progressive insulin secretory defects. So it is, you're going to be, I'm diagnosed maybe a little bit later in life. I have my metabolic friends of obesity, dyslipidemia, fatty liver, sleep apnea, acanthosis, PCOS. And then there's diseases of the exocrine pancreas, like cystic fibrosis-related diabetes, drug or chemical-induced diabetes, like immunosuppressant therapy or glucocorticoids, gestational diabetes while pregnant. And then there's 2 other ones I want to talk about. One is called MODY, which is mature onset diabetes of the young. So these are people that you're seeing, teenagers, early 20s, that come in and they have hyperglycemia. You say, well, gosh, you don't have your metabolic friends, you're not obese, you don't have hypertension, dyslipidemia. I wonder, could you be a type 1? So you send off GAD antibodies, and the GAD antibodies are negative. You get a family history, and you find out that, dad has this also diagnosed early on, because MODY is autosomal dominant, so there'll be a strong family history. So the moment you get GAD negative, then you are sending off for genetic tests, and there's actually a MODY panel. And it is so important to get this diagnosis right to figure out what type of MODY it is, because the defect is what predicts what the treatment is. There's some MODYs that do not require treatment. It's just a sensor abnormality. So they just run a little bit high sugars. It's a glucokinase thing. There are some that are exquisitely sensitive to sulfonylureas. And as an endocrinologist, I would never recommend a sulfonylurea for first-line treatment in plain old type 2 diabetes. But some of these MODYs are exquisitely sensitive to it. So it is the standard of care. So when you think of someone, early diagnosis of diabetes, you rule out type 1, your next step along the algorithm should be genetic testing for MODY. Then we have LADA. LADA is latent autoimmune diabetes of adults. So it's more of an indolent type 1 diabetes. Used to be called type 1.5. So these people are older than the age of 40. They were diagnosed with diabetes initially on pills, but then they kind of morphed into requiring insulin. You look at them and say, well, gosh, you're not your typical type 2. Again, where are your metabolic friends? Where are your obesity, sleep apnea, dyslipidemia, and all those things that go along with it? So even though they're not in DKA, you do get GAD antibodies on them because, again, they don't have the metabolic stigmata of type 2 diabetes, and you find that they're GAD positive. And I would encourage you to do that because it does change the care. It lowers your threshold for certainly putting on insulin and changing from 1 injection to 4 injections a day. But it also increases the risk of other autoimmune diseases. So just like you would screen your type 1 every few years for hypothyroidism, every 5 to 10 years for celiac, now this becomes part of that population where you're thinking autoimmune diseases run together, so you would screen for other things as part of the standard of care. Next question. 36-year-old woman is concerned about developing diabetes. Her mom was diagnosed with type 2 diabetes at around the same age. She's asymptomatic. She doesn't smoke. Her blood pressure is 134/75. Her BMI is 34, putting her in obesity range. What is the best screening method? Fasting glucose, anti-islet cell antibodies, random blood glucose, or no screening is indicated? Excellent. Fasting glucose. In practice, A1C would also be very reasonable to do. Fasting glucose is definitely a better test than an A1C, but the A1C is generally easier to get. So oftentimes, most of us are, sending people for labs. We're going to get a CMP, hope that it's fasting if we're putting on lipids, add on an A1. We're going to get a CMP fasting, hopefully if we're doing lipids, and add on an A1C. So we'll actually get 2 tests. But of the choices I gave you, fasting glucose is hands down the best way to screen for type 2 diabetes. We should start screening at the age of 45, but we can consider screening earlier if there's risk factors for developing diabetes, including family history, gestational diabetes, PCOS, or actually diagnosis of impaired glucose tolerance. And then we want to repeat screening every 3 years if normal. My gut would have told me yearly to follow along, but it's every 3 years is when you want to do follow-up screening if everything is normal. Now, if they actually have a diagnosis of impaired glucose tolerance, then you can justify yearly, but just as routine screening, it's every 3 years. So how do we diagnose diabetes? Well, when we have a random glucose that's greater than 200 with classic symptoms of diabetes, polyuria, polydipsia, unexplained weight loss, blurred vision. Or we're looking for a plasma fasting glucose greater than or equal to 126 times 2. The guidelines are going to be times 2, so you want to repeat these things. A glucose greater than or equal to 200 on a 2-hour oral glucose tolerance test, or an A1C greater than or equal to 6.5 times 2. All right, 56-year-old with type 2 diabetes comes in for a follow-up 2 weeks after emergent vascular surgery. His post-op course was complicated. He was transfused 3 units of packed red blood cells. He reports his fasting sugars are around 100. Before lunch, before dinner, before bed, it's all going high, 250 to 300. Currently, he's on a long-acting basal insulin of 30. His blood count is now normal. His A1C is 5.8. You did point of care testing in your office, and his sugar is 271, and this was after breakfast. Which of the following is the next best step in his management? Do you want to add prandial insulin to his regimen? Or say, look, he's at goal for his A1C. We don't need to change therapy at this time. Or he's below goal for his A1C. We want to decrease his long-acting insulin. Or we want to check for nocturnal hypoglycemia. The correct answer is A. We want to add prandial insulin to his regimen. So A1C don't care about. A1C measures the amount of sugar stuck to red blood cells. So in the context of recent transfusion, you can't get any more information from an A1C. Again, A1C, we're not going to use as for answer C to decrease his long-acting insulin because we don't believe it. And so we don't need to check for nocturnal hypoglycemia unless he's telling us that he's getting signs and symptoms of it. We don't want this A1C to drive decision-making, especially when we can't believe our A1C in this context. So what we want to do is target the prandial excursions with prandial insulin so that we can normalize his sugars throughout the day. So prediabetes or impaired fasting glucose is when your fasting sugars are between 100 and 125. On your oral glucose tolerance test, your 2-hour is between 140 and 199, or your A1C is between 5.7 and 6.4. It is important to understand that not only does prediabetes increase your risk markedly for developing overt type 2 diabetes, but it is also an at-risk situation for both microvascular and cardiovascular disease. So it is not without consequences. The goal is really to reverse this, or at least to prevent progression to overt diabetes. So impaired glucose tolerance, prediabetes, is a real disease that we should be very aggressive in treating. Which of the following is the best way to prevent progression to overt diabetes? Intensive diet and exercise, using TZDs, metformin, or Caribose, which is an alpha-glucosidase inhibitor? Absolutely. Diet and exercise is better than any medication I can give you. Now, that being said, A lot of the diabetes medications do have data on diabetes prevention, but is it worth the cost risk benefit profile? Probably the only one that is reasonable is metformin, because it is generic, it's effective, we have long-term safety data. But if you're talking about, does diet and exercise win over any medicine? Hands down, yes. There's a 50% risk reduction with intensive lifestyle changes. And what does intensive look like? 7% weight loss. So I generally tell my patients they need to lose 5 to 7% of their weight. They do not need to get a normal weight to prevent diabetes. So I'll generally give them a number of the weight they need to lose. And then exercising 150 minutes a week. Again, not that metformin's wrong, but if you had said to me, what is going to be more powerful in reducing my risk for diabetes, it's going to be intensive. Most of us in practice would probably do intensive as well as metformin. We want to monitor A1C yearly and screen for and treat other modifiable risk factors for cardiovascular disease. So treatment for diabetes, it is complicated. There are a lot of families of medications out there, and it is getting more sophisticated the more trials we do. But what you're going to find is that even though we have all these classes of medicine, some medicines are $3 a month, some medicines are hundreds of dollars a month, that when you talk about the efficacy of any medication, it's about the same. The best drop of A1C that you're going to get is probably about a point. And some of our newer, fancier medicines don't even drop it by a point in A1C. So it is important to realize that cost needs to be factored into this. And when you're talking about cost does not predict efficacy. I also like to tell my patients, so I have a hard line in my clinic, that you can't see us in endocrine if you don't see education yearly. It is a no-go. If you miss your education appointment, we push back the provider visit. Because as it turns out, all studies show that an education visit will drop A1C by 1%, as good as any medicine I can give you. And so education is a mainstay of diabetes treatment. Probably more important than their visit with me is their visit with education. Next question. At a routine visit, a 66-year-old is diagnosed with diabetes. She has no complaints. Her exam is normal except for a BMI of 30, making her obese. Her fasting sugar is 230, her A1C 7.9. She has normal renal and thyroid function. In addition to therapeutic lifestyle changes, what would you recommend to improve her blood glucose control? A TZD, a sulfonylurea, metformin, insulin, or cinnamon? People love cinnamon. Metformin, fantastic. Yeah, metformin's pretty awesome. And so not that you couldn't use a TZD, but we do worry about bone health. So the adverse effects on bones, increased risk of osteoporosis is real with TZDs. Pretty much don't like sulfonylureas, and we'll show you some data on that. And again, the only situation I'm ever gung-ho sulfonylurea are on my MODY patients with specific genetic defects. Insulin's going to lead to weight gain, and there are times that we want to use insulin. It's probably when you have symptomatic hyperglycemia that you're not going to be able to reverse with pills, but I never generally run to insulin because of the weight gain associated with it. And sure, she can have cinnamon, but it's not going to reverse it. And it's cinnamon, not cinnamon sugar. Very different. Okay, so which of the following is not associated with metformin therapy? Weight loss, low events of hypoglycemia, reduction in MI, reduction in overall mortality, or birth defects? Not associated. The answer is actually E, birth defects. It's safe to use in pregnancy. So what have we learned about metformin? Like I said, it's been around for more than 20 years. Metformin has been around for a very long time. We have a lot of great data on metformin. We know that it's generally weight neutral to weight loss. of a medication. We know that UKPDS, which was the study that was done a long time ago, which took newly diagnosed type 2 diabetes that stratified them to intensive therapy versus conventional therapy. When metformin was used and we had intensive therapy, that even though over the years the control deteriorated in the intensive group and was about the same as that as the conventional group, that because we were aggressive treating these patients up front, because metformin was part of it, that they had decreased risk of MI, mortality, and diabetes-related endpoints. You're going to hear this terminology as metabolic memory. Okay, so there's this school of thought that the best time to be aggressive with diabetes care is at the time of diagnosis. If you wait to address the diabetes and become aggressive after people have had diabetes for years and years and years, you're actually going to do more harm than good. And that was the pushback we're hearing from Accord. So the moment you take a people with known cardiovascular risk or overt cardiovascular complications and then try to get to control, it's too late. You're going to cause increased events, increased hypoglycemia. That the time to treat and be aggressive is the time at diagnosis, and it's not the time for the inertia. Oh, I'm going to put a metformin on board. Oh, I'm going to add a Januvia. Oh, I'm going to take years and years and years to get control, because then you're going to miss out on this opportunity of this metabolic memory that people are describing. There's very little hypoglycemia that has been reported with it. And in fact, it would be very unusual to have hypoglycemia. It is cheap because it is generic and it is effective. So when we talk about sulfonylureas, that's another medicine that's been around for a very long time, longer than metformin, and it is cheap and it is effective. But why are we so against using sulfonylureas? Because there's actually data out there where there's increased cardiovascular events with using sulfonylurea when compared to metformin therapy alone. And when you have sulfonylureas, not only does it increase the risk of weight gain and hypoglycemia, but the hypoglycemia tends to be prolonged and profound. You have someone that presents with hypoglycemia because they're on insulin. The duration of insulin, they can go home in a few hours once you treat it. Sulfonylureas, it's anyone's guess how long the hypoglycemia is going to stay around. And the risks are even higher in the context of renal disease or kidney disease. So we don't love the medication as a whole. So it's not perfect. Downsides. GI side effects are common. Oftentimes you can alleviate that with a very slow up titration, or there are newer preparations out there that tend to be a little gentler on the stomach. Generally, I'm happy if I can get any amount of metformin on board. It's kind of like the statin principle, that even if I could get one metformin a day, it's a win, even if I can't get them up to the 2,000 milligrams a day. And it can cause a vitamin deficiency. Which vitamin deficiency can metformin cause? B12, exactly right. And so you should be thinking about that, screening periodically, especially in the context of newly diagnosed neuropathy. We want to make sure that the B12 is replete in these patients. So it can't be used in everybody. They have actually changed the insert. So it used to be an actual creatinine that kept you from prescribing it, but now they're looking at GFR. So they recommend not using it if the GFR is less than 30, not starting it if the GFR is less than 45. If you have someone whose GFR is between 30 and 45, but they're already on it and they're tolerating it, they can stay on it, just lower the dose some. So again, you can use it in anybody as long as the GFR is greater than 45. It should be avoided in everybody less than 30. It should be avoided in states that put you at increased risk for lactic acidosis, like decompensated heart failure, when we're using dye, liver disease, sepsis, surgery. So it should be held around those times until the renal function is better, or till you are past that time that we are concerned about the lactic acidosis. So again, sulfonylureas, they reduce A1C by about a point and a half. Some of these older medicines have better A1C reductions because years ago when these medicines were coming out, the control wasn't as good as it was. So conventional control or standard of therapy, maybe your A1C was 9. But now when we do studies, you have intensive where we try to get you down to 6 and 6.5 versus conventional where we let you be at 7.5 or 8. So you really don't see those big drops in A1C anymore like you used to in the older medicines. But nonetheless, that's the data we have. But it probably is not as effective or any more effective than the medicines we have out now. But again, generally considered a poor choice because of the weight gain and the profound prolonged hypoglycemia that can happen with the medication. The next class we'll talk about are the DPP-4 inhibitors. So these are pills that prevent breakdown of your own gut hormones. So we have gut hormones that are called incretins. They are GLP-1 and GIP. And the job of these incretins are to help us recognize food better. And so what they do is they help us recognize when we take food in that food is actually coming in, so we make a more appropriate response of insulin, less of our own glucagon, and we say, okay, we're going to promote satiety, so we're going to eat less. So the job of these pills are not to give us more, but to help us keep more of what we have without breaking it down. They lower A1C by about 0.7. It's a pill a day. It's easy. Weight neutral, which is a win in diabetes. No hypoglycemia, which is a win. But again, very expensive. So there are some situations that we do like to use them as add-on, but we also like to say, look, they're not super effective. You're coming in with an A1C of 10, not my go-to. Okay, because again, the data says about 0.7. Then we have our GLP-1 agonists. So we talked about that we have gut hormones. So GLP-1 is actually one of our gut hormones, and we can actually give people more of this gut hormone. It was isolated from the spit of a Gila monster. And how it works is 4 different ways, just like we talked about what the gut hormones naturally do. Promotes satiety, so we eat less. Slows down gastric emptying, so we feel full with less food. It causes glucose-mediated insulin release, meaning you can take your shot, eat nothing, and you won't have a low sugar. It's only going to allow insulin to be made in response to food and decreases our own endogenous glucagon. Benefits, it's going to lower A1C, significant weight loss, and again, low risk for hypoglycemia because it's a smart hormone. Downsides, injectable, very expensive, medullary thyroid cancer. Your patients are going to say, oh, I don't want thyroid cancer. So it's not associated with differentiated thyroid cancer, which is the most common thyroid cancer, papillary and follicular. But it has in rats, they saw C-cell hyperplasia in the thyroid. So you can't use it for people at risk for medullary thyroid cancer, which again is a very rare cancer. And we worry about increased risk in pancreatitis. So if you have people with a history of pancreatitis, especially if it's unexplained pancreatitis, it wasn't a gallstone or something like that, you would probably want to avoid this class in those people. And then we have the SGLT2 inhibitors. These are medicines that help you pee out glucose even at normal sugar levels. So remember, generally you don't start spilling glucose until you exceed the renal threshold. So until your sugars are more than 180 or 200, you're not going to pee out the glucose. This changes at what level. So what you're doing is you're actually able to pee out glucose even at normal sugars. So it's essentially caloric deprivation that you're doing. So you're losing weight because of fluid, and you're losing weight because of the decreased calories that you're taking in. But because you're peeing out all these sugars, you're making it a very rich environment for fungal infections and UTIs. So you need to be aware of those potential downsides. Also, what has been described and is real is in DKA and type 2 diabetes. And this is generally a harder to treat DKA because it's a euglycemic DKA, which we don't see too often except in certain populations. So when these people come in, they're having nausea, vomiting, you check their sugars, they're normal. You have to have a low index of suspicion to check for ketones. If you do have ketones, what it's going to take to close these gaps is not just insulin because their sugars aren't high, so you're not going to be able to drive the insulin high enough to close the gap right away. These are people that you're going to end up hanging some nutrients, some D5, D10, in order to get up the insulin drip, in order to close the gap and shut off ketone formation. So they tend to be a little bit more treatment resistant than your classic DKA patients that come in with hyperglycemia where you can drive the insulin drip up high. Now, I'm really not going to talk about any more of the data that's coming out because I'm sure you all are aware part of what they have to do for diabetes medicine is have cardiovascular trials out there. So medicine is becoming that much more sophisticated. Diabetes is becoming that much more sophisticated. In your clinical practice, I do think it is worthwhile to know that there is good data out there to use SGLT2 inhibitors in people with heart failure and CKD, and there's good data with GLP-1s with with cardiovascular disease, but the boards are generally several years behind, and I don't think you're going to see any questions about on there about preferentially using one medicine over the other with regards to certain patient populations like CKD patients, like heart failure patients, like cardiovascular disease patients. Maybe in the future, but not right now. But just for your own clinical practice, it is prudent to know that that data is ever evolving, how we should target certain medications to certain populations. So what is the target A1C that we're looking for? We know that younger people, newly diagnosed, benefit from tighter control. And again, this is called metabolic memory. So if there ever were a time you were to get aggressive with caring for diabetes and shooting for normal, it's in the young, newly diagnosed patient. We know that older patients, once they've had diabetes for a longer amount of time, that the risk benefits kind of get skewed of getting tight glucose control, that the risks of hypoglycemia far outweigh the benefits of getting tight control. And so in older patients with comorbidities, decreased life expectancies, you are definitely given some leniency with it, an A1C less than 8 in those that are higher risk. So the name of the game is to get as low as you can safely without having profound hypoglycemia, because hypoglycemia trumps everything with regards to diabetes control. So I can actually change these to the 19 recommendations. So based on the ADA recommendations, what blood pressure in diabetes should prompt a medical start? Should we start medication if it's greater than 120/80, 130/80, or 140/90? The answer is actually C. So not as low as it used to be. So, and again, you can treat people before that, right? You know, part of what we do in clinical practice, you see someone young and healthy, their blood pressure's elevated, have at it. But the time where it's no longer a discussion and you need to start treatment is when we hit that blood pressure 140/90. So the standards of care of diabetes are to get an A1C less than 7. Again, everybody was convinced that this would go much lower with the Accord trial, and the Accord trial did not show us that. The Accord trial showed us that when you try to get tighter control with those people with already vascular disease, you increase the risk of complications. So therefore, the standards of care did not budge. It did not go lower than 7. Blood pressure control, we want less than 140/90. Greater than 140/90, we want to start medications. I'm going to say ACE inhibitors or ARBs are the first line to treat diabetic nephropathy, but this is where I step outside of the board hat and I become a clinician hat. There's some recent data out there with ACE inhibitors and lung cancer. So if you have someone that you feel is going to be on long-term treatment as these patients with nephropathy, probably ARBs are better than ACE inhibitors when we're thinking long-term. Board hat. ACE inhibitors or ARBs are first line to treat hypertension in those with diabetes, especially if nephropathy is present. Statin use is driven by risk and not LDL. You have your patients over the age of 40, they should be on a statin. And we want to check urine for microalbuminuria on a yearly basis. And again, if present, ACE or ARB. We want to do eye examination yearly to check for retinopathy since it's a silent disease. Foot exams at every visit, document a comprehensive one yearly. Smoking cessation and aspirin. Next question. 40-year-old has lost 8 pounds and complains of increased thirst for the past month. She also has a yeast infection. Her BMI is 32, making her obese. Random blood sugar this morning is 380, so fairly robust. A1C is supportive that her sugars are running this high because it's 11.9. What is the best initial therapy for her diabetes? Metformin, sulfonylurea, insulin, or a TZD? The correct answer is C. The truth is all will work to lower A1C, right? But some are going to take more time than the other. The TZDs are going to take weeks because of their mechanism of action. They're activating nuclear receptors. They're moving around fat. Metformin is an insulin sensitizer. It is going to take some time to kick in. Glipizide will work now, but again, do not love sulfonylureas. So when you talk about symptomatic hyperglycemia, the only thing to fix it today is insulin. And so when you are trying to address the symptoms of polyuria, polydipsia, unexplained weight loss, blurred vision, it is insulin, insulin, insulin. Now, that being said, insulin does not need to be hers forever. There's no reason why we can't try to get control with insulin, then incorporate orals or incretin therapy on board along the way. So people are never obligated to insulin who are who have type 2 diabetes. It's just the type 1. So it's a very reasonable start based on her symptoms. So when we talk about insulin, we talk about how we give insulin in the most physiologic way. And the most physiologic regimen is called a basal bolus regimen. Basal is your long-acting insulin. Basal has nothing to do with your food intake. The job of basal insulin is to control hepatic gluconeogenesis, meaning you can fast for days and days and days and days and days and not have a low sugar. And the reason is because your body has stored sugar that it can utilize. So in order to keep that stored sugar in check, we need insulin produced throughout the day so our body knows that we are not starving, so we don't need to utilize those sources. So the basal insulin, again, has nothing to do with food, should never be held on admission for someone with type 1 diabetes, even if they're NPO, because its job is to control hepatic gluconeogenesis. When you hold insulin for someone who has type 1 when they're NPO, their body is going to see it as a starvation state, so they're going to make ketones. Bolus insulin is our mealtime insulin or prandial insulin. It is our insulin that starts working within 5 to 15 minutes and is gone in 4 hours. That is absolutely acceptable to hold while someone is NPO or you're expecting they're going to have poor PO intake. So again, when we talk about basal bolus, we have 2 different kind of insulins that we're talking about addressing 2 different scenarios that are happening. Generally, when you talk about what is the percentage of basal and bolus insulin for someone who is on a full insulin regimen, meaning they have type 1 or they're type 2 and their pancreas has pooped out, it's about 50% of the insulin we need is basal, 50% is bolus, then divided by the meals throughout the day. So for example, if you take somebody that's going to require 40 units of insulin a day, what would be considered physiologic is 20 units of basal insulin, 20 units of mealtime insulin, but divided for the 3 meals. So maybe 7, 7, 7 for breakfast, lunch, and dinner, or 6, 6, 6. And what it looks like here is the yellow line is our basal, again, controlling hepatic gluconeogenesis, and our prandial is to target the meal excursions that are happening. So 3 months after starting basal insulin and slowly increasing the dose, your 64-year-old patient has the following blood sugars. Fasting are 130 and 118. In the afternoon, hitting 250 to 300, and before bed, fairly similar, 280 and 270. BMI is 34, so obese, currently on the metformin and the basal insulin. A1C is 8.2, creatinine is 1.2. Which of the following do you recommend? Increase the metformin, add a sulfonylurea, add pre-meal insulin, or add a TZD. Excellent, pre-meal insulin. And so, again, max effective dose of metformin, even though you can go to 2550 per package insert, is really 2,000 milligrams a day. Sulfonylurea, we don't love. Again, I said that 100 times. Apparently you got it because everybody got it right. TZDs, don't love in older people because we worry about bone health. So the only thing that's going to adequately address, based on your choices, the mealtime excursions is mealtime insulin. Now, that being said, could I have given you the choices of a GLP-1 agonist where I'll get some weight loss with it? Absolutely, that would be awesome. A DPP-4 inhibitor, that wouldn't be unreasonable. It's going to target the mealtime sugars. It'll lower A1C by about 0.7. Or an SGLT2 inhibitor. Again, not unreasonable, but based on the choices I gave you, the most reasonable one would have been the pre-meal insulin. So target A1C, low if you're young and healthy and were newly diagnosed. More lenient if you're having hypoglycemia, limited life expectancy, comorbidities, or you've had longstanding diabetes and difficult to attain control. So bottom line, everybody with type 1 gets insulin, and we never hold basal insulin, even if NPO. If you hold basal insulin, you're going to have someone go into DKA. For type 2, metformin is a rock star. We try to get metformin on everybody. But in the context of symptomatic hyperglycemia, the only thing that's going to fix that is insulin. And the other scenario that metformin can't be used is a GFR less than 30. And again, we have lenient targets for certain groups, and we just got to be respectful of those that are at risk for complications with tight control. It's also going to be important to remember the comorbidities because, part of what I do in addition to the diabetes management is we are talking about the sleep apnea. We're talking about fatty liver. Fatty liver is going to be the number one cause of liver failure now that we've fixed hepatitis C. Hypogonadism, hearing loss, depression. These comorbidities are very prevalent. In type 1, we want to remember the autoimmune friends. We want to think about screening for celiac every 5 years and thyroid disease every 2 years in these patients. Okay, 40-year-old with type 1 diabetes is admitted to the ICU because of sepsis. Weight is 80 kilograms. Outpatient regimen is 20-6-6-6. So a very good regimen. Most people with type 1 are about 0.5 units per kilogram, and that's where this person is. So we're not scared by this regimen at all. He's on the vent and receiving antibiotics and pressors. Which of the following would be the optimal insulin regimen while he is in the ICU? An insulin infusion with a target of 100 to 140, an insulin infusion with a target of 140 to 180, half of the home basal dose plus a sliding scale, or sliding scale alone, also known as correction. The answer is B, correct. And so no longer do we have super tight control in the hospital for the majority of the groups. When we got super tight control, we saw there's actually increased risk of hypoglycemia and no decrease in mortality. So we don't like to keep people that tight. We like to have reasonable control. Now, I caution people, when I say reasonable control, I don't mean no control. I mean keeping the sugars less than 200. It has been proven a long time ago that when sugars start going above 200 in the hospital, it increases the risk of infections and poor wound healing. So even though we say it's more lenient, it's still fairly good control that we don't really want to hit that 200 where we start spilling glucose in the urine. Giving the home dose, half the home dose plus a sliding scale really increases the risk for marked hypo and hyperglycemia. And sliding scale alone is just a recipe for disaster in type 1 diabetes because it's so hard to predict how vulnerable someone is for going into DKA. You can have type 1s that go into DKA within an hour or two, and you have type 1s that might not go into DKA for a day or two. It really depends on what their pancreatic reserve is to determine what that looks like, and you have no idea of knowing. So that would be a recipe for disaster. And so intensive insulin therapy did not show us decreased mortality in the majority of our patients. So our goal is to have reasonable therapy with sugars of 140 to 180. We never want to use a sliding scale as sole means for glucose control in type 1. In type 2, you're allowed to use a correction scale as long as you agree to be reactive today but proactive tomorrow. So put standing insulin on board if necessary. We want to use basal insulin in all patients that are requiring insulin. So if you see every day they're requiring standing dose correction, we want to think about converting that to basal. And we want to add mealtime insulin as needed to control glucose. But at the end of the day, it is so important to avoid hypoglycemia because hypoglycemia will hurt you today. Hyperglycemia causes problems over time. Okay, 46-year-old with type 2 diabetes, hypertension, morbid obesity, BMI of 43, and dyslipidemia, A1C of 9.6, so suboptimally controlled. She's on metformin, basal insulin of 80 twice a day, mealtime insulin of 40, TID-AC, so 40 with meals, and she's on a GLP-1. What would you recommend as the next step in therapy? Increase her basal from 160 to 200 a day, insulin pump, islet cell transplant, or referral for metabolic surgery? Answer is D. So going up from 160 to 200 is just such a small impact, right? Because we look at percent increase. So that really will not achieve the control we are looking for. Islet cell transplant, we really only consider if someone has type 1 diabetes or chronic pancreatitis for preservation of what they have. Insulin pump is not warranted, but insulin pump is never a quick fix. It's a tool for motivated patients. And if we were to use an insulin pump, we'd probably use concentrated insulin in there. So just transitioning her to a pump is not going to get the control that you need. So yes, she meets criteria for metabolic surgery or bariatric surgery. So when should we consider bariatric surgery? It is a recommendation A, that we should consider surgery for those with type 2 diabetes whose BMI is greater than 40 end of the day period. Even if their diabetes control is reasonable, they would be a good candidate for it. You can consider it in people whose BMI is greater than 35 when they don't have good diabetes control. In fact, you can even consider it for people whose BMI is greater than 30 if they're suboptimally controlled, but that is a recommendation B. So bariatric surgeries, sustained weight loss, better than any medications that we have out there for years. There's actually remission of diabetes in a certain percentage of patients. What you're going to find is remission is predicted by duration of diabetes. The shorter the duration of diabetes, the higher the chance of remission. The longer the duration of diabetes, the less chance of remission that you'll get. Improved blood pressure control, improved LDL, and it actually has a very low 30-day mortality. It's that of like cholecystectomy. So they're getting so much better with the bariatric surgeries. Downsides, GI effects, cost, deficiencies of vitamins and minerals, osteoporosis, and hypoglycemia. Hypoglycemia post-bariatric surgery is very well described, and it is a bear to treat. Often it's intensive lifestyle changes, and sometimes that doesn't even fix it, where these people are going for pancreatic surgery or even maybe reversal of the bariatric surgery. So when it does happen, it's generally profound and very difficult. A 24-year-old with presumed hypoglycemia is evaluated during an episode. She has diaphoresis, vocal slurring, and confusion that resolves with IV glucose. Labs drawn during the episode show a sugar that's low at 32, an elevated C-peptide, and elevated insulin. She lives with her parents. Her mom has type 2 diabetes. What is the recommended diagnostic approach? Do an octreotide scan, a pancreas MRI, pituitary CT, get a serum calcium level, or do a screen for sulfonylureas? E, sulfonylurea screen is the right answer. Never image without diagnosis. We are endocrinologists. We don't want to know what imaging shows unless we have a diagnosis, okay? Because the imaging is just going to show us stuff that we have to deal with. And so we only want to image once we have a diagnosis. And remember that you cannot tell the difference between an insulinoma or sulfonylurea-induced hypoglycemia without a sulfonylurea screen, because they are both endogenous insulin production, okay? And so I tell people all the time when they come in for hypoglycemia, we are going to take our time. We are going to take our time and make sure you satisfy Whipple's triad. And if you do satisfy Whipple's triad, then we are going to slowly figure out what the cause is. Because the moment I am convinced that it is endogenous hyperinsulinemia, I will stop at nothing. Even if it means taking out your pancreas, I will do that to prevent the hypoglycemia that will happen. So we really want to be thoughtful and we want to be regimented when we talk about our workup for hypoglycemia, and make sure we have a clear diagnosis before we do imaging, because again, we will stop at nothing to reverse it. So what is Whipple's triad? Whipple's triad is symptoms of hypoglycemia, classic symptoms, shaky, sweaty, nervous, slurred speech, associated with a documented low sugar less than 50. And we choose 50 because in healthy people, you can live in the 50s and 60s. That is fine. And resolution after glucose. So you have to give me symptoms, a sugar, and show me resolution. Then we have satisfied Whipple's triad. Now I'm interested. Now we're going to talk about what is to be done next. Next thing we're going to do is find a time where you are actually going to go low, less than 50, and I have to pair my labs with it. Because remember, there's no such thing as a normal C-peptide, normal insulin level. It's all in the context of what my sugar is, right? So having a detectable C-peptide or insulin in hypoglycemia is inappropriate at any time, but having an elevated C-peptide and insulin might be very appropriate at other times, like if I just ate something or have insulin resistance. So the only way you could ever interpret a C-peptide or insulin level is with a paired glucose drawn at the same time, otherwise means nothing to me. So the moment I pair my glucose with a C-peptide and insulin level and I find out that it is endogenous, meaning neither are suppressed, then I want my sulfonylurea screen. It's going to take a week to come back, and it is going to be a long week, but I am doing nothing despite the patient wanting imaging, despite my fellows wanting imaging, nothing. We sit, we lay low until I get back my sulfonylurea screen. Then if it's negative, we get to go on to the next step. And so again, the question I'm asking with hypoglycemia, is it endogenous? And again, what I am looking for with hypoglycemia is that I should be shutting off my insulin and C-peptide immediately. Your first defense to hypoglycemia is shutting off your own endogenous insulin production. So I should be shutting that off way early. In 70s and 80s, I should be shutting off my insulin. And so if I have a C-peptide or an insulin that's inappropriately normal or elevated, then it is endogenous. Then I want my sulfonylurea screen. And so when we talk about the differential of non-diabetic fasting hypoglycemia, we have the oral hypoglycemic use, which was our case. And again, we're going to find it once the sulfonylurea screen comes back positive. We also could have people that have taken too much insulin, intentionally, unintentionally. Here the situation would be hypoglycemia, elevated or normal insulin levels, depending on the kind of insulin that they're using, but undetectable C-peptide, reflecting that we are not making it, we are taking it. Or you can see it in substrate deficiency. So the people that have been in the unit for days or weeks, that aren't being fed for whatever reason, eventually you lose substrates, and you lose the ability to maintain your sugar, so now you're mobilizing free fatty acids and you're having ketone formation. And so in this context, with high ketones and a low sugar, it is generally starvation. You rule out adrenal insufficiency, but generally these people just need nutrition to get them back to where they need to be. Our last section is going to be on calcium, so we are almost done. We have hypercalcemia and hypocalcemia. So when we talk about calcium metabolism, we are going to start right here, vitamin D. We make vitamin D in our skin. We also can ingest vitamin D. D2 and D3 are what are in food, okay? Vitamin D goes to the liver once we either make it or ingest it. And at the liver, it is 25 hydroxylated, which is 25 hydroxy vitamin D, which is your stored vitamin D. So if you ever want to measure your stored vitamin D, it's 25 vitamin D, not 125 vitamin D. That's actually the more active hormone. So once we have our stored vitamin D, we can measure it, and again, 25 vitamin D. So now let's talk about calcium homeostasis. Very small changes in calcium will lead to huge changes in PTH levels. Your body wants to keep the calcium in a very normal range because calcium is responsible for so many cellular activities. So a small decrease in calcium, huge increase in parathyroid hormone. The parathyroid hormone is going to have some direct and indirect ways to elevate the calcium. It's going to be able to go to the bone to directly get calcium from the bone. It's going to go to the kidney and decrease excretion of the calcium based on PTH. But more importantly, it's going to go to the kidney and activate 1-alpha hydroxylase. So you're going to be able to take all this stored 25 vitamin D, which is essentially inactive, not very active, and you're going to be able to turn it into super active 125 vitamin D, which is called calcitriol. Calcitriol will be able to go to the gut and to the bone to directly get calcium from both places, okay? So again, very small changes in calcium, huge changes in PTH, and it's the PTH that then drives the calcium homeostasis directly and indirectly via activating 1-alpha hydroxylase to make active vitamin D. All right, so next question. Healthy 36-year-old woman is noted to have a high calcium on routine labs. Her mother has a history of a high calcium, underwent parathyroidectomy, was not cured. The patient takes a multivitamin a day. Labs show hypercalcemia at 11.2, a normal creatinine, and a PTH that's at the upper ends of normal for that assay. What is the best next step in management? Discontinue her multivitamin and recheck calcium in 3 months. A check of PTH-RP, which is a related protein. A check of 24-hour urine calcium and creatinine. Refer for imaging, or just refer to the surgeon for parathyroidectomy. C is the right answer. So the scenario they are describing here is FHH, familial hypocalciuric hypercalcemia, autosomal dominant, runs strong in families, right? And so your job here is to recognize that this is what's going on to keep this patient from the surgeons. Now, that being said, the lion's share of PTH-mediated hypercalcemia you are seeing in your practice is going to be primary hyperparathyroidism. There's a very good chance they will be getting to the surgeons. But on boards, they want you to understand the nuances, the pitfalls, the vulnerable patients that we could be seeing. And this is one of them, because you will never cure FHH with surgery. And in fact, FHH does not need to be cured. It is a calcium sensing issue. So despite these people having higher calcium in the blood, they have low calcium in the urine, they don't get osteoporosis, they don't get kidney stones, they don't get kidney disease. It is essentially a benign condition. So your job is to keep them away from the surgeons. Another point for practice to consider is because it is autosomal dominant, they are born with it. So when you have your 70-year-old that's presenting to you with hypercalcemia, it's PTH mediated, you go back 10 years ago and the calcium is stone cold normal, you can feel pretty good in practice, this is not FHH. But as a purist, when you are working this up, you want a 24-hour urine to rule it out, okay? So this is a scenario we want to point out, a situation where this person might have ended up seeing a surgeon and having ultimately 4 glands out because they never would have been cured from it, because FHH involves all 4 glands and it's a calcium sensor mutation. If it were due to her multivitamin, that's calcium intoxication or milk alkali, the PTH would be low because the calcium would shut it off. If it were due to PTH-RP, which is malignancy, the PTH would be low because with the high calcium, because of the PTRH, it would shut off the PTH. We would never image without a diagnosis, ever. And in fact, primary hyperparathyroidism is a biochemical diagnosis. I don't care what my imaging shows. It is what the diagnosis I make with my labs and not imaging. And I would only refer for surgical consideration after we have ruled out FHH. And so the diagnostic approach to hypercalcemia is a repeat, and then decide is it PTH mediated or non-PTH mediated. So you draw the PTH level with the calcium level. Of the PTH mediated, the lion's share is going to be primary hyperparathyroidism, and the lion's share of those are going to be single gland disease, because remember you have 4 parathyroid glands. Of those, 80 to 85% of the time, it is going to be a 1 gland disease. So it's always great if you can know in advance what gland to start at, and that's where imaging becomes your friend. But it doesn't make or break your diagnosis. It has nothing to do with your diagnosis. It is just merely a starting point for the surgeon to know what gland to start at. And of course, we have to differentiate it. And especially in someone young, healthy family history, we want to make sure that it is not FHH. And that's where we do our 24-hour urine calcium, and we find that it is actually very low in FHH. And then there is tertiary hyperparathyroidism, which is more the common context of long-standing, poorly treated end-stage renal disease, where you have a very elevated PTH level. Essentially, that 4-gland hyperplasia you get in end-stage renal disease, one of those glands will become autonomous. And so generally in secondary hyperparathyroidism, end-stage renal disease, you have a super high PTH, normal calcium. as an evolution in time, as those parathyroids become larger or one becomes autonomous, now you have a very high PTH state, now at a high calcium in the context of end-stage renal disease. So tertiary is really utilized for that patient population and the patient population that's post-transplanted 1 year of after surgery. Pitfalls. So lithium can cause hypercalcemia. Actually, it can look just like FHH because lithium impacts the calcium sensor. So we are always asking for a lithium history. Sometimes the hypercalcemia does resolve with stopping the lithium, sometimes it does not. And hydrochlorothiazide can definitely cause hypercalcemia. There's some argument whether it actually causes it on its own or whether it just unmasks primary hyperparathyroidism, but as a purist, we would stop the hydrochlorothiazide for 3 months and then reassess. And if the hypercalcemia is still present, that's when we would go on and evaluate for primary hyperparathyroidism. Primary hyperparathyroidism is more common as you get older. Generally, it's a single gland disease. When you are seeing multiple glands involved or parathyroid hyperplasia, we are thinking more familial disorders such as an MEN1 or 2A. And again, it's a biochemical diagnosis. I make that diagnosis. High serum calcium, PTH that is not low, I will take inappropriately normal or elevated. My urine calcium excretion is not low, so I've ruled out FHH. The moment I have made that diagnosis, all my patients become a candidate for surgery. But who should I force surgery on or really say it's no longer a choice? So remember, any of your patients can get surgery. That's never a problem. But who should you really say should go for surgery? Anybody that's symptomatic. Anybody that has a markedly elevated calcium level, greater than 1 upper limit's normal for your assay, because we worry that that long-standing hypercalcemia, it can lead to a nephrogenic diabetes insipidus, dehydration, it can cause calcium deposits in the kidney. Anybody who has poor kidney function along the way because you don't want to put their kidney at a disadvantage with filtering all this calcium. Anybody with kidney stones or at risk for kidney stones where they have a high 24-hour urine calcium excretion. Anybody with osteoporosis and anybody young. You know, if they're going to be dealing with this for the next 20 or 30 years, why not do something that's curative, one gland disease, and just be done with it? And then that way you don't have to worry later on if they develop osteoporosis or some CKD that it's the hypercalcemia that's contributing. And so when we talk about non-PTH mediated hypercalcemia, we actually have a good differential that we like to go to. These tend to be our more interesting cases that we see. Malignancy can cause hypercalcemia different ways. One way, it can actually produce PTHRP. PTHRP acts just like PTH, meaning it elevates the calcium level. And so this is the tumor making a protein that looks just like PTH. You could have it in the context of multiple myeloma, where you actually have destruction. This is generally, you see the triad of hypercalcemia, anemia, and acute kidney injury. You can have malignancy causing hypercalcemia with activated macrophages. We see this in B-cell lymphoma. So generally, it's the kidneys that make 125 vitamin D, right? That's super tightly regulated by PTH. But when you have extra renal activated macrophages, you can actually have 1-alpha hydroxylase there. So in diseases like sarcoid, TB, lymphoma, in these activated macrophages, you could take all this stored 25 vitamin D and make 125 vitamin D, which then will cause hypercalcemia. You can have milk alkali, which is, the people popping Tums all day or taking huge amounts of calcium. And the triad there you're thinking about is hypercalcemia, alkalosis, because it's a milk alkali, as well as acute kidney injury. Vitamin D intoxication, you can see it with 25 vitamin D, and you can see it with 125 vitamin D, where people can take too much of it and could cause hypercalcemia. And then we're always thinking hyperthyroidism and adrenal insufficiency as less common causes, as well as immobilization. And immobilization is one of those harder ones. That's that squirrely consult you get in the hospital, someone long-standing in the hospital for a few weeks, their calcium's trending up, their PTH is low, you can't find anything else going on, and you're just calling it kind of immobilization, so you try to get PT involved, hydration, and do that. It's really hard to make the diagnosis, but it's probably a lot more common than we acknowledge. And so what are the clinical manifestations? Usually if it's mild, it's usually asymptomatic. That's why the cutoff for surgery is greater than 1 point upper limit normal, because generally less than that, you're not getting a lot of symptoms. Once it does start to go higher, then you can see the nephrogenic diabetes insipidus causing polyuria, dyspepsia, bone demineralization, kidney stones. And once it's greater than 14, that's where it puts you at risk for lethargy and coma. Independent of the etiology, you can treat with fluids. So it's hydration, 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 because really what we're trying to do is impact the nephrogenic diabetes insipidus that causes the polyuria. So we want to maintain the fluid status, and that will help reverse the hypercalcemia. You can also use calcitonin, which is a calciuretic, so it's going to allow you to pee out calcium. It's short-lived, its effect, but it'll help you for the first day or two while you're trying to do the hydration and figure out the etiology. Then you can target therapy based on the etiology, where you can use bisphosphonates if it's something like a cancer or multiple myeloma. You can use steroids if it's 125 mediated, like sarcoid TB or lymphoma. Mobilization if we think that this is immobilization. And you can always do dialysis to fix both hyper and hypocalcemia. It's a quick fix. So when we talk about hypocalcemia, one of the most common etiologies that you're going to see is surgical destruction from people having thyroid surgeries. That being said, it can be autoimmune, but it's generally much less common. When you have profound vitamin D deficiency, you can get hypocalcemia. We think of this in our bariatric patients, our celiac patients, our nursing home patients. Loop diuretics can be a cause, and low calcium intake like alcoholism. You can get paresthesias, you can get spasms, tetany, you can have your Schwazdeck sign, you can have life-threatening things, including spasm, cardiac arrhythmias. I think it is important to know the classic EKG changes, which is QT prolongation. And anytime someone is symptomatic or has EKG changes, the treatment is IV calcium. You can always give an AMP, which is a baby dose, about 93 milligrams of calcium. And then if it's sustained, then you can do a calcium drip. All right, down to the last two things we're going to be talking about. First is osteomalacia, which means bad bones. You do have to keep in mind that not all fragility fractures are due to osteoporosis, that metabolic disease is real. And what happens with osteomalacia is that there's profound vitamin D deficiency. And because of this profound vitamin D deficiency, there's calcium and phosphorus that is low and a very high serum alk phos, and that should be making you think of it. Low calcium, high alk phos. The treatment of this is going to be replacing the calcium and vitamin D, because if you were to target the osteoporosis with a bisphosphonate, it is not going to get you better bones along the way. What you need to do is replace the mineralization. The last disorder we're going to talk about actually has increase in alk phos also, like profound vitamin D deficiency. But in Paget's disease, the calcium is normal. Paget's disease is a focal disorder of bone remodeling, where you get areas where there's high bone turnover. It's generally asymptomatic because we're finding it much earlier than we ever have. And so we're finding it based on labs. So on labs, you see an unexplained elevated alk phos. You get a vitamin D level. The vitamin D is normal. Now you're looking for Paget's disease. So what you do next is you go get a bone scan and you look for areas that light up. If there's any concern that it's not classic Paget's disease, you can always get an x-ray of that area. We used to say there used to be thresholds for treatment, where we would treat people if they were symptomatic, like had pain over that area. We would treat people if they had bones that could fracture, so if it was in their vertebrae or long bones. If skull was involved, we would worry about the deafness. But the treatment, the data is so good with a one-time treatment of zoledronic acid that we pretty much have a low threshold that we would treat anybody with Paget's disease, because the majority will go into remission with a one-time treatment of zoledronic acid. So the pearls. Random hormone levels are rarely useful in endocrinology. Rare endocrine diseases are common on the boards, unfortunately, so you need to think about them. Never image without a diagnosis. Autoimmune diseases run together, and statin is always the right choice for those with cardiovascular risk. So statin benefit, need statins. That is it. Thank you for your attention. Good luck.